So, ich glaube, wir starten. Ich begrüße Sie.
Okay, I think let's get started. Let me welcome you to our OCT course for the advanced users. That is really a super interesting topic, and we have a super fantastic panel that we have prepared for you from 5 countries, very high-ranking experts who will also introduce us into OCT beyond not only the standard, but also everything. And we are going to directly start and skip introduction because we have really very well-known OCT users, and I think this is going to be honored with 2,200 or even more participants that we have, and we have a great number of registrations that we've gotten, and we would like to start immediately. Let me welcome also my panel from Sulzbach. That is Boris Stanzel, the Privatdozent Stanzel, and the head of the section of the Macular Sprechstunde, one of the greatest competencies in macula. Then Philipp Roberts, who joined us from Vienna 1 year ago. He has fellowships in medical retina in Australia and the USA. He has done that, and since 1 year he has been here, and he's a great enrichment for our macular competency and how we can present ourselves in a very modern way. But before I hand over the facilitation or moderation, I would like to welcome the first speaker, Barbara Parolini. And one more thing. First, if you want to use the interpreter function, please use the Zoom app, not directly through the web browser. Otherwise, you will not have available the interpreting function. It takes only 2 minutes. You can also do it in between. And if you have questions for the panel discussions, that is also going to take time, please use the Q&A function, the F&E function, as it's called in German. The speakers are going to see that, and the certificates automatically will be sent to you, but it's going to take like roughly 2 time, and Gerling Kongresse is going to do that.
Very excited to welcome you, Barbara. Barbara Parolini is from Italy, from Brescia, a fantastic retinal surgeon we know for a long time. And she's also a highly recommended specialist in myopia, a personal weakness for me, and I'm very excited to hear your talk. You're currently not in Italy, but in London, right?
Yes,
so
yes.
I'm very happy that you have made it possible to participate. So, Barbara, your topic is myopia and the OCT biomarkers for myopia.
Exactly. Thank you so much. Let me jump into this topic. I have too many things to say. So let's see why OCT biomarkers are prognostically valuable in high myopia. We all know that high myopia is about long eyes, and I would not focus on the refraction because it varies in literature. These are eyes that are longer than 26.5 millimeters. The prevalence is 2% of the global population, but is rising, so this is probably wrong as defect. Uniform or non-uniform elongation of the eye is the origin of every anomaly in pathologic myopia. And this is what I mean between uniform and non-uniform. You see it depicted in this 3D MRI image of high myopic eyes. Not every eye with high myopia have a staphyloma, only 50% of them have, and the one that has a staphyloma have mostly wide macular staphyloma involving the macula and the papilla. This is one of my patients shown with wide field imaging, wide field OCT, and I have seen that in the projection image of the wide field OCT, you have the perfect design of the contour of the staphyloma. This is another example in multi-image. The second most common type of staphyloma is the neuromacula, you see involving only the macula. Then the peripapillary staphyloma involving the papilla where the macula is on a slope. The nasal and the inferior staphyloma are less common. So the OCT biomarkers are all consequences of the staphyloma in high myopia. This is the list and we will see them one by one. So even when everything seems normal, you look for the deepest side of the eye and you find the problem. Let's start with lacquer cracks and CNV. The choroid breaks because of the elongation of the eye. The choroid breaks and new vessel comes from the choroid under the retina. Myopic CNV are typically small, difficult to see, associated with little or no fluid at all. And finding a CNV in a symptomatic high myopic eye sometimes is like finding a needle in a haystack, but then with patience, you do find it. OCTA is not always that helpful, and I would say that symptoms of the patient, sudden metamorphosia, are very important guiding you to the choice of treatment. As biomarker in OCT, I would say that the change from low reflectivity to the high reflectivity contour around the lesion is the best biomarker to tell you that the CNV has responded to treatment. The second feature in high myopia is atrophy, because the choroid gets thinner and thinner, and then not only you have lacquer cracks and breaks, but you have large areas without choroid that are very often associated to collection of serous cavity that I think are mostly related to RPE deficiency than traction. Here you see two eyes of the patient with two different aspects. And when in color you see almost nothing, remember that you might have traction. So this is the third feature of high myopia, which is myopic traction maculopathy. MTM is visible only in OCT. And I would say wide field is the most informative imaging type to really design the contour of the eye. You see here the difference between a macular detachment with macular hole scan with the standard OCT versus the same eye with the wide field OCT. It's not only the width, it's the depth of field that allows you to see what happens in these eyes. There is no way to see with standard OCT this type of contour. So in 2020, I have published the myopic traction maculopathy staging system because, as you know, MTM is a large family of OCT aspects that are all collected in this single table. Here, there is everything you need to know on MTM, from the evolution perpendicular and tangential to the macula, to the average visual acuity, and the time taken to evolve from one stage to the next, so you have a prognostic data for your patient. You can tell that MTM starts in as inner macular schisis and evolves to the outer layers of the retina. And then in stage 3, you have a combination of schisis and detachment. And in stage 4, the retina is completely detached. And if you look at the retina itself, there's no schisi left. So for each one of the 4 stages, look at the inner fovea. In stages A, the fovea is intact, while in stage B, there is a lamellar macular hole, while in stage C, there is a full thickness macular hole. It's been validated at an international level, and I would challenge you to nominate every OCT with an MTM, not with maculoschisis, generically speaking, but with the stage. Look at the macula, select 1, 2, 3, 4, then look at the fovea and select A, B, and C. So this is stage 1C, this is stage 4A, and this is stage 3AO. So what about the capital O and the plus? These are 2 additional very important biomarkers. Let's start with the outer lamellar macular hole. If that is the area of maculoschisis and the foveal detachment, you see in the infrared this whitish area. Could that be atrophy? Well, if it is atrophy, and there is backscattering in the OCT, you expect to find black in autofluorescence and white in the color. But in the autofluorescence, there's nothing and not in the color. So what is that? And that area actually disappears when you treat it surgically. That is an outer lamellar macular hole, which is an interruption in the lines of photoreceptors and induces backscattering in the sclera, but no hypoautofluorescence nor atrophy. It has been described as a very important feature, surgically speaking. This is the outer lamellar macular hole. And here you see the difference between the inner and the outer lamellar macular hole. About epiretinal proliferations, I want to highlight that this is the inner limiting membrane stretched by the schisms. This is not epiretinal. There is no separation between the inner line and the retina. While here you see an epiretinal proliferation with a separation between the line and the retina. And that is important because in the first case, you don't need to remove it. You don't need to treat it. You can buckle the retina, resolving the case as you see in the image in the bottom. While if it is epiretinal, it is important to remove it with a vitrectomy. So the same table has been then enriched with guidelines to treatment, which are based on the OCT features based on the stage. Here you see an example, pre-op on the top and post-op on the bottom, where with the macular buckle, I have treated the detachment, while with the ILN peeling, I have treated the macular hole. One word on Tiltis disc syndrome, which and dome-shaped macula, which is the fourth feature of this high myopic eye. This is the less known and more recently described. Only in 2008, Gaucher described the dome-shaped maculopathy, which is an asymmetric growth of the eye wall. And in the macular region, you find increased scleral thickness and an inward protrusion of the sclerochoroid retina of at least 50 microns compared to the rest of the profile. And the dome-shaped macula apparently increases in height over time, but it's not the dome shape that increases in height, it is the surrounding choroid that elongates. In fact, the total axial length increases in time. Again, the cause of dome-shaped maculopathy is unknown. It is supposed to be a resistance of the macula to the elongation to preserve a metropization. You can find a subretinal fluid, CNV, but no MTM because the dome-shaped macula has a natural buckling effect. And typically subretinal fluid is resistant to any treatment and it goes up and down spontaneously in time. I have my hypothesis. I need to prove it. I think the eye wall growth has a posterior portion that is inducing an asymmetric scleral thickness along the eye wall. These are very difficult to depict with any type of imaging because they have huge and significant deformation. But I think it's also genetically determined because I have two twins, very similar patient, very similar fundus, very similar retina. You see the macula is vertical and they have ongoing up and down subretinal fluid that I've known and since years. So I think there's a gene that can explain the situation. It's very important, the concept of progression in high myopia, because as a staphyloma can grow from young age to old age, from type 2 to a type a deeper one, and as well as atrophy can progress, and it's been demonstrated by Kyoko Ono Matsui, and MTM can evolve. This is a patient of mine. You see the evolution in years. So everything evolves in high myopia. This is another example. So I think that if we find a way to stop elongation, we will be able to stop myopia and all the complications. I have an ongoing study showing that with the macular buckle, I have a slower progression of atrophy and elongations compared to the non-operated eye, but it's ongoing and it has to be demonstrated. Thank you.
Barbara, thank you very much for this quick overview of what
I'm sorry.
myopia.
I had too many things to say.
No, this is fantastic. I mean, you know, we were talking with Peter that basically we meant to sort of entice the speakers by saying that diamonds are created under pressure but you know, myopia is such a huge field that is exploding these days.
Yeah.
You know, I have a million questions for you, and so let me perhaps start off with, because you know your surgical expertise in myopia is huge. So you know, right now there's one perhaps the two most common discussions are a foveal sparing ILM peel in cases of non-penetrating holes in these myopic traction maculopathies, how to repair also macular hole retinal detachment. And there was a question from the audience that asked, what is a macular buckle?
So a macular buckle is a device made to shorten the eye. Since, as I have shown, every problem starts with the elongation of the eye, I think the rationale to try and treat macular detachment in the posterior pole is to shorten the eye. So we are fighting the cause. So if we are able to shorten the eye, we can not just treat, but also prevent progression. My advice is to treat the schisis and the detachment with a macular buckle, so with eye shortening, while if you want to close a hole, you have to go inside the eye and use ILM maneuvers to close the hole. So macular buckle and vitrectomy have to be, you know, combined and selected based on the stage of MTN.
Macular buckle is really very interesting approach to treat these macular holes in high myopic eyes. But you know always my concerns. The problem with the macular buckle is that it puts pressure on the short ciliary arteries, which enter the eye directly underneath the macula. And yeah, I've asked you a lot of times, do you see sometimes this ischemic side effect of macular buckle surgery?
Thank you for this question, Peter, because now I have 15 years follow-up of my first patient, and I have been studying ischemic problems and atrophic progression in these eyes. I have compared the operated eye versus the non-operated eye, and I could see that there are no changes in both groups. So it means that the macular buckle, for some reason, does not induce atrophy and does not induce ischemic problem. Actually, when you reverse the pathology, vision improves. And you see not only in letters gained, but in microperimetry and visual field. So I cannot tell you why, but I can tell you that in a very long-term follow-up, this does not happen. Macular buckle is protective.
Do we have time for one more quick question?
Yes.
Just for clinicians for everyday practice, so I had a good look at the staging, and in stage 3, for example, you had some subretinal fluid.
Yes.
Would you indicate surgery in these cases purely based on the staging, or would you make it dependent on the function? What is the function in stage 3? Are they still
depending on the function? So yes, of course there was too little time, but in the table you have the average visual acuity that I found in the group of patients that I studied for each stage. So in stage 2, the photoreceptors are still attached, so you can have good vision. But in stage 3, when the fovea detaches, then is the time of drop in vision. So the average visual acuity at that time is 1/10, 20/200, how you want to say. So that is the time of surgery. And if you don't have any hole, like stage A, 3A, 4A, I have published this case series. macular buckle is the best treatment. You don't have to touch the retina. You do a macular buckle only. It will reverse the pathology and it will never progress.
Very good.
I know everybody's scared about macular buckle. I am not, because that's what I've been doing for the last 15 years. Now it is available. There is it's a new design, very easy to implant, and I'm about to publish the technique, but it's very easy. Every one of you can do it.
Sounds very intriguing. Thank you.
So just to
Thanks.
clarify for those who don't know what is a macular buckle, and it is not very popular in Germany. It is very popular in Arabic countries, in Italy and some others. So it's still a spotlight therapy. A macular buckle is a support like a spoon. It looks like a spoon. It is sutured in the interior part of the sclera, and then it goes like a spoon around the eye and supports the macular part from behind. So I'm more and more interested in this intriguing topic.
Peter, I'm sorry to interrupt you. I didn't include it, of course, in the talk because it was about biomarkers. Do you want me to show a picture, or maybe there's no time? I can send it.
We have the time. Yes, please do so.
Okay. So this is it. This is the last model. You see it is in PMMA. It's like a J with the button that it's called the head of the buckle, and an arm with holes that allows to suture the buckle anteriorly. So basically you open the quadrant, you measure the distance from the limbus and place the first suture, and then here it is how you implant the macular buckle in the eye. In the superotemporal quadrant, I use this inserted because it makes everything easier. And then you place the suture into the holes. That's it. So I will stop the presentation, otherwise I will take too much of your time. Thank you.
Thanks a lot. Fantastic. Just one final remark.
Thank you.
I was very happy that you have shown the difficult differential diagnosis between an epiretinal traction, epiretinal membrane, and a schisis. And just so you help to clarify why it happens sometimes that we become referred patients for maculopapular surgery in those myopic eyes, and maybe the referring doctor is disappointed because we send him back that there is nothing left to peel. But this is explained by exactly your fantastic images. Not every epiretinal structure is a maculopapular. But sometimes it's just the schisis, and it's not a good idea to peel the inner part of the retina.
Correct.
So
very well.
Thank you. I'm available personally for any question, so I don't take your time. It's parolini@gmail.com. So just write me and I will answer every question.
Yeah, thanks a lot. Okay, prepare my talk. Boris?
Okay. Yeah, so Barbara, thank you very much for your presentation and the great discussion. It is now my great pleasure to introduce Prof. Schulman, the head of the department at the Eye Clinic Sulzbach. He's going to tell us about biomarkers of the outer retina that matter towards vision. Peter, please go ahead.
Ja, wir springen wieder erstmal auf Deutsch. Diskussion machen wir wieder auf Englisch.
We are going to jump the presentation in English. You can use translation, Barbara, if you want to follow the translation function on the globe that you see at the bottom line. And then, so now we're going to talk about my favorite topic, the outer retinal layers in OCT and why they are particularly important. That is what I always look at first. We have to admit that OCT gives us so much information, but to be honest, we only use it for two things. First, for diagnoses, we have a great pattern recognition, and in all these pictures, we immediately see the diagnosis because we are very experienced in that. And second, we use it for therapeutic monitoring, for example, where they need a thick retina syringe. If not, that describes my everyday act. So here we look at the retinal layers and we have to understand them and what is hiding behind them. And most of all, I would like to put a focus on the 4 outer retinal layers because that is one take-home message. They represent different structures that we are going to go through, but these 4 layers, they represent the photoreceptor integrity and function, all the 4 of them. So we first look at the ELM, the external limiting membrane. That is made up, but here the midicendris from the ILM to the ELM to ILM, that is part of the structural integrity. And that is even more important. It's not a real basal membrane, but here we see many tight junctions with occluding parts and a quick and a firm cell barrier, only semi-permeable. In many diseases, it plays an important role because this is a compartment between the inner and external retina, for example. So the semi-permeable membrane protects the underlying inner and outer photoreceptors segments. Secondly, we have an ellipsoid zone, which is my favorite membrane, and I always look at the ellipsoid membrane. It was a bit obscure until 2014. It was called the ISIS line, the inner segment, outer segment line, because it was somewhere between the inner and outer segment. Now, we call it ellipsoid zone as of 2014, and it's only a few micrometers, but it changes everything in our understanding because we see what has changed. We know that this second with reflective blend through the mitochondria in the inner segment are formed, and the mitochondria here, they are fully packed. So here we see this lower cone. This is the power plant of the photoreceptor. This is the metabolic part of the photoreceptor. That's why the ellipsoid zone shows the health, the inner health of the photoreceptor and also the function. You're going to see that the ellipsoid zone correlates with the visual acuity and very significantly. The 3rd and 4th membrane, I take them together, which is the RPE layer that you see here, probably through the phagosomes in the interdigitation zone. And then we have the RPE Bruch, probably caused by the Bruch's membrane, the choriocapillaris. That is very important, that also the 3rd and the 4th membrane, they are also a marker for photoreceptor health. So the RPE layer is not separate from the photoreceptors higher above. They are also biomarkers for the photoreceptors. Why? Because the interdigitation, for example, of the photoreceptor outer segments with the microvilli of the RPE are represented. That is the second message that we shall take along. All 4 layers represent the RPE layer. And we see that the 3rd and 4th band shall not be discriminated against. Here you can still distinguish between the 3rd and the 4th band, but in many cases, also in a completely healthy eye, here you can see in many areas there are junctions between the 3rd and the 4th layer. So it's absolutely okay if you call it an RPE layer or band. If you don't have a clear discrimination between the 3rd and the 4th layer. So this is the interdigitation zone, which is the reason for the photoreceptors. The ellipsoid zone, the 2nd layer, I say it's one of my favorite layers because it's the perfect marker for the photoreceptor integrity and health. And mainly if we have outer retinal diseases, this is in, for example, in rod dystrophia or achromatopsia, for example, cone dystrophy, or also the early Stargardt, for example, where there are no big changes in the eye. You see that the ellipsoid zone at a very early stage is interrupted. And that is a sign for the fact that we're going to have a loss of visual acuity. But an ellipsoid zone, for example, it's not only about interruptions of integration or not. There can also be alterations if you have cyclical, for example, diseases, mutes, for example, the ipsiloid zone completely disappears, but after a few weeks it comes back. So the layers come back. In other APM, PPE, for example, inflammatory diseases, the EZ is also disturbed, but even if the problem states, there are still changes in the ellipsoid zone. That's why the patient does not get a complete restoration of the visual acuity. AMD is a very good example to show how the ellipsoid zone correlates with the vices, and it's very highly significant. For example, the retinal pseudodruses, for example. But if you look at the zone, it's almost not there. It shows that why reticular pseudodrusen lead to a loss in visual acuity very early, and the intermediate AMD it does not look so different, but it's normal drusen that we have, and they have a completely intact vices. And here the ellipsoid zone jumps above it, and there are no integration problems, no disruptions, and only if the AMD is progressing with PEDs, for example, if there is liquid, then the ellipsoid zone disappears quite quickly, and the NAMD very quickly. But due to the retinal thickness, if it's still okay, there is no loss of the acuity. But nevertheless, the patients think that they see bad. And also in geographic atrophy, for example, it's not the scantral scrotum that correlates with the NAMD defect. For example, you might say that this is the blank plate. Here is the central scrotum. No, the central scrotum, for example, is then defined by the ellipsoid zone. And here the ellipsoid zone, for example, starts to have interruptions and irregularities. And the central scrotum, for example, is much bigger than what we see at a first glance. So the ellipsoid zone in everyday life is very important, and that is what I always look at. This is a great example from everyday life. Two patients, for example, with macular pucker, Mysis 06. They did not want to get an operation, although it looks quite wild, but we could say we can leave it like that, for example, as long as the visual acuity is stable and it just goes down step by step, like on a staircase. So what do you think? What has disappeared? I mean, it's not the retinal thickness, but one of them could see much worse, only have 0.25 in visual acuity. Why? Because the ellipsoid zone tries to be a bit milky and not very clear. There are irregularities and discontinuities. For example, the other layers are okay. Also, the ELM is completely okay. The retinal thickness has not changed. And that is the reason for the loss of visual acuity. And here you have to do a surgery very early, and also at the top, it's not necessary. Also in retinal detention, for example, very often we do that, and visual acuity is super. Then we have other cases, and visual acuity is super bad. Why? Because the ellipsoid zone, for example, and the length of the photoreceptors are very important biomarkers. This is how you measure it from the ELM up to the top of the outer segments. And here you can see that in the best case, we have a completely intact ELM and also a great length of photoreceptors in the inner outer segments. And there at the bottom, if you have no ellipsoid zone, for example, no inner and outer segments, for example, then the vices becomes very bad. So preoperatively, you can also predict how the visual acuity is going to be after a successful retinal detachment repair. Also, in vein occlusions, for example, we see that there are cases we give syringes, everything is dry, and the visual acuity is great. And in other cases, it's successful drying, but the visual acuity is bad. So look at the ellipsoid zone. And here you can see, for example, because also after drying the edema, for example, the visual acuity is not built up and the ellipsoid zone is not built up. And in the diabetic macular edema, you can explain it much more when it comes to venous inclusions, for example, or also if you have diseases on the inner retina, for example. But as long as the photoreceptors and the ellipsoid zone is intact, and the ELM, for example, is closing, for example, it's really protecting the underlying ellipsoid zones, for example, the photoreceptors, the internals, example, with their dry junctions. As long as we have these dry junctions, the visual acuity remains intact. It's incredible how much time an eye can really bear with humidity and wetness. So this explains, for example, and the last example I wanted to show, after macular foramen surgery, we see, for example, that it takes after 12 months until the visual acuity increases because the ellipsoid zone quickly builds up again, but, no, sorry, the ELM quickly builds up, but the ellipsoid zone needs at least 12 months to restore. And if it's not fully restored, the VISUS is not going to be good. And that is the approach. Many of you have seen, for example, that after macular foramic surgery, we give micro impulses for 6 months. If you have had a good surgery, but nevertheless, as you can see here, we still had a defect in the ellipsoid zone and three micropulse treatments. And after that, the ellipsoid zone built up again. So it's all about the ellipsoid zone and the markers for visual acuity. And it's all about the 4 layers that represent the visual acuity. And there perhaps the focus is shifting for how can we, for example, to make sure that we enhance and strengthen the regeneration of the ellipsoid zone to get more retinal survival. That is a big issue for our macular disease treatment. Thank you so much. Okay. I think we have 2 minutes to go for questions.
I have a question.
Yes, Barbara, go ahead.
Barbara, go ahead.
Yes, okay. This was a fantastic talk. I really would like to have it for me. But so what about the ability to rescue the outer retina and the ellipsoid zone? To what extent can we rescue dead lines? So the underlying question is, how soon should we treat pathologies, especially with surgery? Epiretinal membrane, for example, does it make sense to intervene earlier in order to prevent the disruption, and to what extent they can be rescued? You saw that with nudes, they can re-show or come back. Can we do that with surgery as well?
Yeah, first of all, for example, in full thickness macular holes, all layers are disrupted. And then, although the ellipsoid zone is a marker for visual acuity, I look for the ALM as well, because the ALM restores first and then the ellipsoid zone. And there are even hints in literature that restoration of ellipsoid zone needs an intact ALM. As long as there is no ALM, you will fail in hoping that ellipsoid zone restores. The second is, for example, in diabetic macular edema, I also focus on the ALM because the ALM is a protection border for the underneath lying layers. So if I have macular pucker together with the diabetic macular edema, I look on the integrity of the ALM, and this gives me an impression how much resistance will have the outer retina on these diabetic macular edema.
We have one.
Good.
Sorry. Is it okay
No,
to?
I'm sorry. In the interest of time, we need to move on. Es ist jetzt eine große Ehre für uns, Herrn
For us, it's a big pleasure to welcome Professor Priglinger from Munich. Professor Priglinger is a great expert in macular holes, and we're looking forward to his
Dear Boris, dear Peter, thank you very much for inviting me to take part in this webinar. I'm really happy and delighted to take part. Congratulations for the great agenda and program you set up. So I've been asked to talk about lamellar and penetrating macular holes, and I will talk mainly about prognosis as well as prediction, how these parameters will evolve. So it is important to assess the success of my surgery intervention. Then I will talk about biomarkers for lamellar and full thickness macular holes. So laminar holes, as for the laminar holes, what we want to know? We want to know we are interested in the prognostic biomarker. We want to know the course, the natural course. Do I need surgical intervention? On the other hand, the predictive biomarker. Second important thing, because this tells us if I do surgery, will my surgery intervention be successful? As opposed to the full thickness macular hole, that is different because so the incident happened or has happened already. There is a larger hole, and what I want to know, if there is surgical intervention, how about its success? What can I do for my patient? What can I tell to my patient? Well, the non-penetrating macular defects, I split them up in three groups. So the pseudo holes, then you see the second center here. As for the foveoschisis patient, same thing, but in addition here we have a retinoschisis at the level of the handle fiber layer. And as opposed to these two situations, referring to the lamellar holes, here we have a loss of tissue. So the retina in the middle is thinner. So the retina becomes thinner and thinner, and later on there might be what you can see here. So the so-called lamellar hole associated epiretinal proliferation. So there you have a morph material. You can see in dark the changes, the layers affected, as opposed to the elastic beans. You can see the difference here. And in former times, this has been called epiretinal proliferation. Today, we call it only because we find it somewhere else as well. Whenever you have this kind of a change, this is a sign of chronicity. And today we know, and that has been published already, how we know the microstructure of these changes, as you can see here on these images. We have so we have the myofibroblast single layer in the middle, myofibroblast multi-layer, vitreous collagen, and as for the foveoschisis, there we have a multi-layer phenomenon. And as for the, you could see it, and in order to make it even more complicated, because it's not always as we want to have it in daily life, often we can see that there are transitions between two different things. You can see the changes here, which typically may occur. and then it is more difficult to decide what will be the impact of my treatment. Well, now that we know how an LMH appears, let me show some examples. So all these changes are changes on a macular hole. Shall we wait or shall we treat? You could see in the middle a loss of visual acuity on the right hand in older patients. It's quite okay. Visual acuity 0.5. So, do we know already if and how we shall treat or not? No, we still need prognostic and predictive biomarkers. Well, here the situation is rather stable in between 1.5 and 8 years of follow-up. So you see the amount of change, the percentage of change. Predictive biomarkers. Here I can say, explain to the patients the impact on the visual acuity and associated with the evidence of LHEP. So here, visual acuity will be worse, and here we will have an increase of intraretinal splitting. And if you have a low thickness of the retina, so then the prognosis will not be that good. A very nice biomarker, that's the evidence of tractive ERM, because then you know the natural course and how it evolves. And as you can see here, stable visual decline, pseudo visual decline, or LMH stable, and LMH plus ERM worse. And as for the prognosis, and that's important for your surgery, if there is a pucker in addition, then it is quite likely to have a huge improvement. In the second case, it's not really better. In the third case, LMH plus ERM will be better with the membrane. So here it will be much better. So, question, is there really no effective therapy for these degenerative changes? And maybe you learned about this already. Currently, there are 2 or 3 new variants. On the one hand, the use of plasma, platelet-rich plasma with highly concentrated thrombocytes. So these thrombocytes will be applied to the patients. The patient must be laid on his back. And here you can see how it evolves 1 week after the surgery operation, and then on the right hand, 3 months later. So finally, how to manage this? You could see the different factors. We learned about the factors, and now we want to know if we can treat the patient, because here we have a patient with not a lot of problems. Here we could use the thrombocytes, but we can tell to the patients that how about the likelihood. So that's why here, wait and see, wait and observe. That would be the right approach here. Then here, in this case, it is recommended to do surgery, no thrombocytes needed. And so the example shows the outcome after 3 months after surgery. Last patient, 70 years old, metamorphopsia. So, and here we can say, here we wait. But 8 months later, you can so same patient. Really, there is a problem. So what was this a mistake? What's the problem? Let us have a look at the literature. Literature teaches us, shows us that if we treat a patient that most FDMH derived from LMH had at the beginning a small diameter, but on the other hand, we can see and learn from literature that the prognosis regarding the treatment says that 40% 40% improvement of visual acuity, 10% worse. So once again, we need a biomarker, and there is one which may predict if an LMH may turn into a full an FTMH. And here we see 50% hyperreflective stress lines before the formation of the FTMH. And if you consider our case, specific case, here, once again, we can say that we had a hyper-reflective stress line, and maybe here we would have needed to do surgery intervention at an earlier stage. So, is there something new as for the functional outcome? Well, the classic biomarker, the macular hole size, the intraretinal cysts. If you have intraretinal cysts, so then your prognosis will be worse. But then there is a new biomarker, so-called supra-RPE deposits. So there's remnants of PR segments, and that says that there will be a correlation with the outcome. This is still discussed, as opposed to this predictive biomarker. And this refers to the edges. It depends if it is bumpy or not, if you have bumps or not, and it has been proved that there is a correlation. The more it is bumpy, that has an impact too. So bumpy versus smooth. Another important criteria. Summarizing it all, the morphologic biomarkers are helpful for us because they help us to identify and classify pathological changes of the vitreomacular interface, and that enables us to prognose the natural history of different entities and important negative predictive biomarkers for lamellar macular hole and OCT are the photoreceptor defects, the preoperative evidence of epiretinal proliferation, and a foveal thickness of lower than 100 microns. And the hyperreflective stress lines may serve as a prognostic biomarker for the progression to an FTMH. Important predictive biomarkers for a full thickness macular hole in OCT are the macular hole size, the macular hole border configuration, the existence of cysts, maybe the border configuration, they may be bumpy or smooth. Thank you very much. Well, I'm just coming from the University of Munich, so thank you very much.
To Sigi Priglinger for this really fantastic quick overview on macular holes and lamellar macular holes. Sigi, I have two questions for you. First of all, because this is an OCT course, you know, you mentioned these hyperreflective stress lines. So sometimes they can be slightly eccentric. So what is your preferred imaging protocol when you look at lamellar macular holes?
Oh, in which direction are you thinking? I'm not really sure whether I understood your question correctly.
Yeah, so you know, so sometimes when you do the B scan, say on a Heidelberg machine, we know that it's somewhat fixation dependent, and if there's a hyperreflective stress line, that is clearly foveal center.
We need this. Sorry, we need the star pattern, of course, yeah, because we sometimes miss changes. It's the same. I think the example I showed you, where if you go just one line, just look at one line, the horizontal line, you would have said, okay, it's just perfect. But if we would have looked, which we actually did after we had seen the patients with a full thickness macular hole, if we would have looked more exactly, we would have seen those hyperreflective line, and maybe together with the patient would have decided to do the surgery in advance and not waiting until the macular hole occurs.
Boris, we have 2 minutes time, and we would like to bring in the discussion Sandrine Zweifel and Thomas Ach. So we have time for one question. Hyperrefractive stress lines, bumpy borders, perfect biomarkers, what we have as a take-home message. But in those cases, you can also bring it down to a disruption of the ellipsoid zone. You have perfectly seen that both the ALM and the ellipsoid zone start to disrupt, and then the macular hole developed. Is this also an explanation for this hyperreflective stress line?
I have to admit no idea, to be honest. But the only good thing, the good news is that we have learned using dromocytes, high concentrated dromocyte with the cytokines. We even see a regeneration of the ellipsoid zone, which I think is really spectacular. I just heard you that you are using the laser even to stimulate the regeneration. Is
the
this
micropulse laser.
Sorry?
Yes, a micropulse laser to restore or enhance the restoration of the ellipsoid zone. But we have an expert for the outer retina, Sandrine Zweifel. I'm sure that you can contribute. Hello.
Thank you very much. Yeah, I think there is also what you should consider is also the possibility of lateral displacement. So when the hole is not that large and you just have like in the outer retina, let's say a small gap, this is possible that by lateral displacement that it can be closed by itself. But even more important, I think, what Professor Priglinger said, that you need to be very careful. Don't rely on just like one single B scan. Always, when you don't have to have the time to do like a high resolution or a fine raster OCT with like minimal size between the B scan, what is always good for screening is the OCT star. So at least you have an information in all the direction. I think this is even more important. And when you follow this patient closely, I agree. I mean, it's you have to look at all the different biomarkers to decide at each individual, is it the right time to do surgery or have you still time to wait? And then I think what is also an additional factor, and we heard that also in the first talk, if a patient is myopic or not.
Yeah, I would love
to continue
this discussion for an hour, but we have to proceed. Philipp, would you like to announce, Sandrine?
Okay.
Und Sigi, vielen Dank. Ich weiß, du hast eine Parallelveranstaltung.
Thank you very much.
Danke, dass
You have a
möglich
parallel
gemacht
meeting,
hast.
second meeting in parallel. Thank you very much for taking part. Great event,
So
great
we
webinar.
are now very
Thank you
happy
much.
to introduce Sandrine Zweifel from the University Hospital in Zurich, and she will be giving a talk about submacular pigment epithelial detachments.
Vielen herzlichen Dank für die Einladung.
Thank you so much for the invitation. I'm happy to be part of this course. And in the next minutes, I'm going to tell you a bit about the pigmental epithelial detachment. My financial disclosures are not so relevant for this talk. Pigment epithelial detachments, we see them very often in the clinical everyday life. The specter is huge. And now we are going to take a closer look to see what do you have to watch out for in the clinical everyday life. This is an older patient, as you see them probably very often. She has still quite good visual acuity. 1.5, and we have Drusen and soft Drusen, for example, confluent, for example, and we have a focal hyperpigmentation, etc. And we see no bleeding. Of course, also nowadays we do multimodal imaging to make sure that the information can be brought together of these different identities, and we see that we have many hybrid fluorescent parts. If we go through the OCT and we scroll through it, here we see on the one hand the smaller Drusen, the confluent parts, and also here at the center, the big pigment epithelial detachment, the hyperreflecting eye, and also the areas of fluids. So the hyperreflective changes that we have. And the question now is, for example, do we have to do something therapeutically? If we look at the conventional imaging methods, combined fluorescein and endocyanine green angiography, here we see a staining of the drusen deposits. Then here we see no hyperfluorescent plaque. And the question, for example, is, does the OCT angiography give us additional information or not? Not always, and not with patients who have big pigmental epithelial detachment, because there are certain limitations concerning segmentations. Of course, here you can look at the ID picture, for example, whether you can see a flow or not, or is it a non-neovascular pigmentation? Clinical everyday life, you can be very pragmatic and say, for example, you have to look at the patients in a short interval. You look at him after 2 or 3 weeks, for example, you do a follow-up and you do another OCT examination. And this is what we have done. And here you can see that the hyperreflective area, we believe that its subretinal fluid is practically unchanged. So what do we have? If you have pigmental epithelial detachments, you have to look at the different forms of fluid that you have. More in detail, we have intraretinal fluids that you can see in the first picture. We have subretinal fluids, for example. We have RPE fluids below the pigmental epithelium, and then we have the hyperreflective material, which is neovascular. And we also have transudats, for example, non-neovascular fluids that come from the loss of the pumping function of pigmental epithelium. And that is a non-neovascular AMD, what you can see in this graph very well. These patients, of course, they do not know an intravitreal IGF therapy, and it's very important that these forms of pigment epithelial deposits in the non-neovascular area, the transudative fluids, can be distinguished. Now, a second case, what we also see very often in our clinical everyday life. Here we see the hyperreflective changes in the subfovea, subretinal area, and we see a very small pigment epithelial detachment. If we look at the OCT result, we see that in addition to the hyperreflective material, there are also fluids in the course that pop up. What you see here is a time relapse over 2 years. So you see initially the hyperreflective material in the subfovea area that is increasing. There is a more liquid, and you see this homogeneous choroidal hypertransmission once that the material has dissolved, and it leads to an atrophy, to a large atrophy. Concerning biomarkers, you could say that it's subretinal hyperrefractive material. You could call it like that. And here we have the complete atrophy of the outer retina and retinal pigment epithelium, also called cirrhora, under the newest classification. If we look at the patient, then we have to look at the definition. Of course, this is, we need biomicroscopic, for example, also for a definition of the lesion. This has been to be hyper autofluorescent, for example, and it has to correspond in OCT in the B section with the subfovea hyper reflective material. Then we talk about a so-called acquired vitaliform lesion, an AVL. What shall you tell the patients that you see in your clinic? How is going to be the progression if you have a so-called AVL? In hardly any cases, for example, I would tell them to do a resorptions of the vitaliform material and to a restitution of the outer photoreceptors and the pigment epithelium, so to avoid an atrophy in the course of things. And here you can see also a timeline of 3 years. That happens very rarely, because we usually have to tell the patients that usually they are going to have a collapse of this material in the course, also later to a resorption and then to a large atrophy, of course, with a massive loss of visual acuity. If you want to know more about these changes, we, together with Christine Kershaw in Alabama and the New York group around Bailey Point, we looked at the vitaliform lesions, and we have done a clinical evaluation and also histopathological evaluation. What you can also take along for yourself is usually we talk about a long time first. Then these material deposits are going to increase, and in the course of time, they are going to develop an atrophy. And very rarely there is also a resorption. I only know about very few cases, and you also have to tell the patients that in the course of their disease, within 2 or 3 years, they will have a strong loss of visual acuity. What are the biomarkers? And what are the findings that we have together with the vitaliform lesions, for example? We have so-called pigment epithelial detachment also in these changes. We very often have hyperrefractive foci. We have a splitting of the pigment epithelial detachments and the Bruch membrane. And this shows that here we have laminar deposits. We also see a change in the integrity of the ellipsoid zone. That's important for the visual acuity, and not rarely do you have a hyperreflective thickening of the pigment epithelia in the basal lamina. And in this area, there's going to be a blockage, a choroidal shadowing. What is the take-home messages? For example, a vitaliform lesion is nothing else than a subretinal hyperreflective material that you have in the OCT per definition. It has to be yellow in the color fundus photography, and it has to be hyper autofluorescent. Unfortunately, there is a high risk in the course to have a loss of visual acuity due to atrophy, the cirrhora, high risk of progression, and if macular near an MNV, for example, might be intravitreal syringes hardly needed. So in our center, it only happened in 2% in Zurich. Supraretinal fluids usually are not related to other membranes. Now let's have a look at another case. We have a patient who's 84 years old with these hyperreflective and hyporeflective parts. Is it also a pigment epithelial detachment or not? In the upper part, in superior markers, we have a large subretinal fluid deposit, and it's not a pigment epithelial detachment, but it is a so-called ballard. What is that? That is a basiloid detachment, a ballard, and in this case is also an AMD patient. We have a hyperpigmentation. We also have a bit of a yellowish lesion that you can see here. The vitelliformis material is also here. And if we look at the OCT angiography, also a so-called type 2 membrane. So what are these bacillary layer detachments, the ballards, for example? So within the inner photoreceptor layer, the myoid zone, for example, we talked a lot about the ellipsoid zone, the outer part, and now here we have to look at also lateral forces. We see a bigger influx of fluid into the splitting between the inner photo receptor segments. That happens very often if you have inflammatory diseases, the Koyanara syndrome, for example. That would be a normal OCT, and in this bacillary layer detachments, the ballard, for example, you see splitted within the inner photoreceptors in the myoid zone. Now, if we look at these patients in the course of time with Dantulichev, they were treated. So we have macular vascularization in the angiography that we could prove. Unfortunately, the ballards, for example, have a very bad prognosis. Even if the liquid and under therapy is regressive, usually, as you can see here to the right, after a 6-month follow-up, there are also the ellipsoid zone then cannot be shown anymore. And to sum it up, the bacillary layer detachment has to be distinguished from pigment epithelial detachment. It's not pathognomonic for AMD, and it has a very bad prognosis for the people. What can we see here? We see an older patient, or we have autofluorescence OD. We see in both eyes that we have this reticular pattern that shows that we have subretinal drusen deposits, for example, in the left eye. We also have large areas of hyperautofluorescences, for example, that correlates with the OCT images. And if we look at the right eye, what we see here is a so-called splitting of the retinal pigment epithelium in the Bruch membrane and a double layer sign. What does that mean, this double layer sign? In OCT, for example, if you look at a double layer sign, it shows that there is a high sensitivity for a type 1 macular vascularization. This means that if you don't have an OCT angiography, you know that if you have such a double layer sign, that there is a high risk for a conversion to an exudative macular degeneration. Now the question is, would you inject if you have this vascularization of the macula, as you can see in the OCT angiography? In this case, would you inject? We have the fibrovascular pigment epithelial detachment, but no intraretinal fluids. So what would be the reasons, for example? for treating such a patient. One reason could be that she would have a better visual acuity in the long run, or that you can prove that the conversion rate to neovascular AMD is lower. And this is what has been done in 2 different studies. We looked at syringes, for example, with non-exudative. How high is the risk for conversion? Is that lower? And that was not the case. So these patients shall not be treated because they will run a risk, even if in a randomized way it's quite low, but it's an unnecessary risk, and the patients are not going to benefit from preventive injections. Apart from that, we also have to say that this type 1 macular neovascularization, for example, is progressive for the development of a dry AMD. Here you see a patient, you see the choroidal hypertransmission, for example, it's completely stable even after 3 years, because this big neovascular network is underlying, and we could prove that by looking at the growth rate of atrophy. So, non-exudative MNV, currently there is no evidence to treat these patients. Thank you for your attention.
Sandrine, thanks very much for this amazing deep dive into pigment epithelial detachments. One entity that we haven't mentioned at all is central serous chororetinopathy. I think this is also oftentimes a diagnostic dilemma, because central serous often comes along with very shallow RPE detachments that may or may not have harbor and MNB1. We also, I'd like to welcome Jay Chhablani, one of the world experts, in fact, on central serous. So I would actually like to throw the word right at Jay, because I mean he's published so many papers on central serous.
Thanks, Boris. Thanks everybody for inviting me. Good morning. Yeah, I was not ready for the question early in the morning, but yes. So I think it is very important to really differentiate type 1 secondary to macular degeneration and type 1 secondary to central serous. If you really ask me, it is not very easy. But to start with, I would really like to look into the choroidal thickness and look at the choroid. If the choroid is thin, then it goes in favor of macular degeneration. If the choroid is on a thicker side, then it goes on to in favor of CSC. It is, I don't think that now we hold anymore, oh, if you have a young patient or if you're an old patient, because now we all understand that CSC could be presenting late, even in the older population. But I think the more important and interesting observation is that get an autofluorescence done, and the autofluorescence is going to show you a much more diffuse area of damage in central serous, which may be very distinct in AMD, corresponding primarily to the macular degeneration signs such as Drusen or geographic atrophy. But I think the way the diffuse autofluorescence changes we see in central serous, that makes the differentiating central serous from AMD much better.
Okay,
thanks very much.
For Boris, we have time for one very last short question. Sandrine,
it has to be very short. I'm sorry to be the sort of the messenger of inconvenient truth.
Don't let Sandrine go before answering this question. Very important, but also disappointing that most of these pigment epithelium detachment related special diseases are not really treatable with anti-VEGF. Do you think that these PED-related CNVs might benefit from Vabysmo because it has another approach?
This is a good question, and actually this question we always ask ourselves when a new treatment is available. And in the beginning, we are very excited, and we look at the first patients and think that there might be a stronger effect for PEDs. But what we have from data so far, I don't think that the effect of the Ang2 is really greater on PEDs than the anti-VEGF drugs alone. But anyway, I mean, it's good to have, like in very resistant cases, to have more than one molecule available. And we don't know, maybe IVR 8 milligram, which has started to also treat patients with the higher dose. Maybe that has a better effect. But I think that the bar is already so high that there is probably a certain percentage of patient. It's hard to tackle like PEDs or even like, let's say, other issues like fibrosis. We are not, it's not possible yet actually to manage. And regarding the PEDs, I mean, that is also a question. Is it always good to have a flattening of the PED? Because resorption and flattening of the PED might also be like the first stage to develop atrophy.
Thanks a lot. We could continue for a million of years with this crazy discussion. Thanks a lot. Boris, you would like to announce Jay? No, it's Thomas Ach, right?
No, it's Thomas Ach. So now it's a great pleasure, eine große Freude, einen persönlichen Freund.
So it's a great pleasure to welcome a personal friend of mine, Thomas Ach from Bonn. And his task was to distinguish and differentiate so the yellow underneath the retina, so which is called drusen. Is this right or wrong? So Thomas, please, the floor is yours. Yeah, thank you very much, Boris, for the invitation. Thank you very much for the opportunity to take part in this well-organized meeting. So the matter to know is, drusen, do we find them in OCT? And does this mean automatically AMD? And during the next 7 minutes, I would try to guide lead you to this topic. So do we need OCT to detect drusen? And what's important, where you do your RCT record. So that was my conflict of interest. I've been working with Christine Porcio. Thank you very much to her for allowing me to use her material. So she was a great teacher. So Mrs. Zweifel showed some OCT images of the macula. She's an expert, and even if the image is running through quickly, you can see there are different types of drusen. Drusen detected on the eyes, and we have to distinguish them. On the one hand, so the soft drusen, so quite large, some cuticular or pseudo-drusen, as we call them. And what's important, and that's what we said earlier, so an OCT transversal cut, what you should try to know, where on your retina do you do this cut, and what part of the retina do you observe? So recently we published what you can see here. So we have this segmentation here, the inner, central, outer, near periphery. So your 4 different regions, outer radius, and that is important because the drusen, as a general term, these drusen may generate different deposits on the eye. So recently published here by using OCT technology, OCT cuts through the object and the ANFAS observation. So then they made an evaluation of this, and what they said, there's a three-zonal distribution of drusen deposits. So there are typical zones of this deposits. So as you can see here in blue, that's the soft drusen, mainly found in the center. Then you have the subretinal drusenoid deposits. I will come back to this later on, rather in types of bands. You can find them on the inner and outer ring, and then you have structural end-phase OCT images. And if you take your cards, if you segment it, if you consider the different layers of the retina, layer by layer, if you segment it this way, well, you need the right software to do this. So the subretinal drusenoid deposits. So there is another risk. So there is a recognized risk factor for the future development of the disease. So there are different types of imaging to check these deposits. OCT, there are other techniques. Infrared reflective imaging. What we do not know yet, comparing to soft drusen, we do not know of the SEDs, the sub-RPE, if there's a certain amount or a certain quantity important for the function. What we have here, so that's an alternative way to do it. As for the retro mode imaging, we have the confocality. The optical path presents a small central pinhole to let only light coming from the focused plans in. And the deposits then, you can see them. It looks like surface, like a pseudo three-dimensional image. And if you correlate it to the OCT imaging, so then in retro mode as well as OCT, that's what we did with a group with intermediate R&D. Well, you have to know where you are on your eye. The typical sub-RPE, so soft drusen, are mainly found in the central area, in the inner area, and anything in the outer area. So the typical are so 4 up to 6 millimeters. So there you have huge deposits. And what is interesting to know, with soft drusen co-localized to the region of greatest cone density. So there you have a huge amount of cones. And as opposed to this, so the SDDs are mainly found in the area of greatest rod density, and that might have an impact. That might be a reason that why there are deposits. So once again, an example of subretinal drusenoid deposits, as you can see here on these 3 images. And if you consider the amount here, the concentration, so as for the volume, in part they are larger, but there is a huge amount of subretinal drusenoid deposits, 1200 here, distributed here. They are very small, basically, as for their size, and that's why it is difficult to consider its direct impact on the function of the eye. What you can see here, if you consider these, you can see changes, detect changes at a very early stage, the soft drusen, and you can see them again. Here you can see the detachment on the level of the soft drusen. Here on the right hand, as it is marked here, the underlying epithelium. And as opposed to the subretinal drusen, here you have a soft sub-RPE. That's the main risk factor for the future development of the disease. If you have soft drusen in the center, if you can see it on the OCT, then the matter is, as you can see here, and what is important as for the importance and the distribution. So that's a result of the work of a work group here. The largest volume of drusen can be found in the central area. That's what you can see here. So you find it here in the middle of the retina, and there are differences as for the distribution, as for the histology. There are different possibilities. Soft drusen in the center, in a circle, inside the center, you find this type of deposit here. Basement layer, soft drusen. So other changes here. So like the stars in the sky. Here you have a colorization of this change of drusen underneath the pigment epithelium, and here the soft drusen material. Here, as you can see here, it is different. So it is important to distinguish this. So there are different stages. So the retinal pigment epithelium, and so then here you have this kind of an accumulation of material. Why does this occur? Why does this happen? And why there is a drusen regression? If you consider cultures with small holes enabling the RPE cells to get separated. Then you may see similar aging processes, thickening of sub-RPE material. So that's quite good to see. And as for the difference between the SDD and Drusen, so the immunohistochemistry, so the lipid colorization, there are different distribution of cholesterol, which cannot be seen on the SDDs. The cholesterol inside the drusen, you can see it here. Here you can see different lipid ultrastructures of deposits, different origins of these deposits. If you consider the metabolism of lipids occurring on the outer retina, so everything occurring below. So the RPE may generate lipids, but there are different lipid metabolisms on the level of the photoreceptors, and due to this, you have this accumulation of this material as opposed to the soft drusen. So, so the drusen may change, they may progress or regress. So often you have this regression too. So there might be migration between the different layers of the retina, and this may be a multifocal appearance. It's a kind of strange if you consider all these changes. The soft drusen mainly occurs in the center, in the central area. But well, there are different mechanisms. We have these deposits of this lipid material oxidizing, liberating free radicals. But on the other hand, we have protective mechanisms, as you can see here. If you consider the images, and it's surprising to see this. So these protective mechanisms are associated, if you want me to say, to these harmful processes. So maybe the pigment has a protective function, and as for the harmful mechanisms, so we have to consider the different zones here. And coming to the end, and to my conclusion, the question was, when I see drusen on the OCT, does it mean it is AMD? Is this true or not? Well, the field here, extended field, so you may show all this by means of your OCT. If you have soft drusen in the middle, so then you have there is a high chance SDD outside the central subfield, then there is a high chance of AMD as well. If you can analyze this further, in addition to OCT, autofluorescence would be enough. So you would then get more information. But well, we do not know yet why all these things occur this way. Keep in mind, please, all these changes we refer to have to do with the distribution of the clones of the cones, excuse me. And well, we have many experts here on the panel. We should address the topic of patchy drusen as well. So these are yellow-colored deposits as well, due to changes or changing metabolisms. And as here, that might be related to a process of thinning. Well, there are some metabolism processes. So thank you very much, Boris, again for the invitation. I'm really happy to be here and take part in this webinar. Thank you very much.
Fantastic overview. We'll switch to English.
For this fantastic presentation.
I have noticed that we have Professor Ursula Schmidt-Erfurth also in the panel already, and so I would perhaps throw the question at her now that I have pressing, because Thomas, you mentioned that if you're in the central ETDRS grid, you have SDDs, then this is AMD. But you know, sometimes we have patients that only have SDDs, but they don't have so-called drusen, and at least by definition, AMD, the hallmark for AMD are drusen, soft drusen. So I would like to perhaps see what the opinion of Prof. Erfurth is on this perhaps somewhat controversial entity.
So there are multiple types of drusen, as we have heard, and the key hallmarks as they were defined in the 50s, long time ago, nobody of us was planning to be an eye doctor, not even there. So drusen started as a very fuzzy word for yellowish deposits of any kind. And this is when also shortly after the term was coined, these are hallmarks for AMD. There wasn't so much differentiation. What we know now, with having available much more advanced imaging, we can differentiate drusen. So, and we can also differentiate the different features that are leading to advanced AMD. In our spatial temporal observation about drusen and then conversion to AMD, drusen were seen in the center. Yes, the soft drusen that we talk about, they come and go. Yeah, they become bigger, they become smaller. That doesn't necessarily lead to anything. Only 15% of drusen regression leads to geographic atrophy, for instance. Then we do have these other SDDs. They are more in the outside of the fovea, and this is where geographic atrophy starts. So we didn't find any correlation between soft drusen and the origin of geographic atrophy. Of course, if a drusen becomes very big and very high particularly, then this will lead to malnutrition of the overlying photoreceptors and RPE, and they will die out. This is another type of the progressive geographic atrophy disease that we are usually referring to, which has nothing to do with soft drusen, has nothing to do with drusen resolution, and starts outside of the fovea, where there may be SDDs, but no soft drusen. That's my momentary take on it. Ask me again next year, then we know even more probably. What do you think personally?
Was that my question? So I'm come back to Boris' original question about SDDs. You're right that there are some patients you will see SDDs but no soft drusen, and the question is that also AMD? Well, probably some kind of aging process, in the subretinal space, maybe related to the photoreceptor systems. There are a lot of discussions going on whether also blood flow or choroid capillaris blood flow might impact the development of these deposits. I think at this time point, where we just started to see them and start to learn more about them, there is absolutely no definite answer. So ask me in 2 years.
Fantastic. Very well. I think in the interest of time, we have to move on.
Okay. So our next speaker will be Boris Stanzel, who is an absolute expert in medical retina and the director of the study center and the macular subspecialty clinic at the eye clinic in Sulzbach. And he will be giving a talk about atrophy of the outer retina. Boris, stage is yours.
Yeah, thank you very much for the quick introduction. So, ich werde jetzt wieder auf Deutsch sprechen, wie wir das vereinbart hatten, die deutschen Sprecher.
Thanks for this introduction. I'm going to continue in German, but you have interpretation right inside of Roche. Their products will be mentioned. In the past, we have looked at geographic atrophy with the fundus autofluorescence, and we are learning together with OCT that this method is more and more insufficient. In Sulzbach, we have a natural cohort with more than 300 patients with geographic atrophy, and some of the pictures come from this cohort. We've also learned with OCT, we have a much more granular assessment of GA. And here you see the development of GA. I'm going to show it with a laser pointer. And please look at this area. This is over 3 or 4 years. You can see that between the papillary and the macula on the outer fovea, for example, there's a small area. But if you look at it in OCT, you can see that this process can be seen much more in detail with a small drusenoid detachment, which is regrading. We also talk about ghost drusen, and in English, the subsidence, for example. Then they are going to disappear, the ordinal and the photoreceptor layers. And then we have choroidal transmission effect up to a complete atrophy of the retinal pigment epithelium of the outer retina. And you have also heard that in course of time, a term has been coined, for example, that characterizes much better atrophy development. This is a consensus of atrophy meeting, for example, that has come together, made up by experts. Some of them are also our speakers here today, and we are enormously proud of the fact that they are here today. And last but not least, we have learned that the geographic atrophy is not only an atrophy of the retinal pigment and the outer retinal zone, the ORA and RPE and RORA, but also the existence of STDs, as we have seen excellently in the last talk. And it's also a retinal atrophy. And very often, it's mixed types of both integrities, for example. How do we define C-RORA, complete retinal, outer retinal atrophy, for example? We have 6 examples that you can see here, different patients. And last but not least, you can boil it down to 250 micrometers in diameter, fluorescence or choroidal transmission effects in SD, OCT, or in the infrared reflection imaging. If you see that in a patient or in multimodal characteristic, then per definition, the patient already has a C-RORA or GA, or also a late form of an age-related macular degeneration. It's very interesting because there are more cross-sectional examinations. For example, intermediate AMD patients up to 40% show the C-RORA lesions, for example. Here you see a histological split of what you have, and also as Mr. Ach has shown, for example, here this is the retinal pigment and retinal atrophy. For example, we have a complete pigmental absence or a beginning outer retinal atrophy, for example. These are some characteristics of the lesions, but not completely. And the same image we have for the C-RORA or the C-ORA, for example, incomplete or complete atrophy, depending on the omal thickness, which is already left or not. And the STDs also here play an important role when defining the atrophy. At the beginning, I've shown this case, and if you have followed closely, you see that here in this area, there is a little splitting of the Bruch's membrane and the AD layer. And in such cases, we have to really see whether we don't have a quiet SCNC by Kirkish, as I have already described. And this is also called as non-exudative macroevascularization type 1, and the equivalences are very different, but the progression rates, also due to a meta-analysis shortly published by Jakob Raus from Denmark, in the first year, they are 20%, and after 2 years, up to 30%. There is a conversion in different statistic models into an exudative AMD. And Sandrine Zweifel also answered, no, you should not treat that in advance if it's not exudative. In a progression of the PD height, I would start treatment. Now, if you have a large GA, then there is a question of the foveal involvement. And looking at the OSLO, for example, or the fundus images, for example, you cannot say that because very often the autofluorescences are masked by the pigments and the OCT. For example, foveal sparings, for example, which is very interesting, allows for that, or a foveal involvement of GA. Foveal sparing or foveal involving GA is possible. And here very often the difficulty is to differentiate, for example, between the form of lesion, which is not so easy. And if we look more at the foveal sparring GAs, for example, I would like to say that AMD, for example, here we see traces in the interface between the retina and the Bruch's membrane, and here we can see some images. I would like to pick out the bottom right. For example, here we have crystalline drusen, multiple drusen, for example, that pop up. And so you can see that subretinal architecture is different from others, because here we have a Schramm lesion, for example. And if you look at that in angiography, we do not see very much. You could almost call it still a staining, but if you look at the OCT angiography only at the center, for example, the algorithms until now, they have problems in doing right signaling. So here in this case, we also can talk about the exudative macular degeneration. And with Vabysmo, there has been a treatment, and you can see that the lesions are disappearing, and that we also have an increase in visual acuity. What is controversially being discussed at the moment, and there are many works done on that, for the lesion, for example, can there be protective medicine, for example, or treatments? From Rosenfeld in Miami, for example, they have found out that if we have the lesion, for example, that is bad for the progression, I think the jury is out, and we have to also look at new blockers. Another thing that I would like to mention is the material that we have an interface between the choroid and the retina. How do you distinguish between complementary therapies, for example? How do you differ between dystrophies that might look like an AMD-related atrophy from a geographic atrophy? And one hint might be the interface of the retina, which is very often very smooth. We show that another image here. We have a dark choroid, for example, atrophy also seen in OCT, compared to an AMD type lesion, for example, where you still have a lot of material left. Then I would briefly, and Professor Schmidt-Erfurth is going to say much more about that later. I would like to point out that the changes in the different biomarkers that you can see in OCT, that you can also pick them up with artificial intelligence. This is an algorithm of website who also has been proved, and I'm very grateful for the slides that they have given us, because if the assessment of a study of Artemis, for example, we can see how the photoreceptors are affected, which are usually outside their RPE or the RPE damage. And other therapies to the left, for example, compared to the fellow eye, for example. So if we do a quantification of both sides and we look at that in parallel in phase 1 studies, here we start. Now, for example, it's a 50% reduction of the damage in both treatment arms, 1 or 2 months compared to sham. And this takes me to the conclusion: geographic atrophy on OCT is called CRORA or ORA, and the non-exudative MNV often coexists with geographic atrophy, or starting serious lesion is very often a risk factor for having an AMD. The fovea-sparing GA is more accessible to treatment, as I already mentioned, mainly if you think that it's the glaucoma of the retinology GA, and if you want to do a complementary modulation. And the role of MNV on progression of GA also remains controversial at the moment, but many of us believe that it is protective, and there are different AI algorithms that can evaluate GA progression, and that is a response to treatment and assess the response to treatment. And the retin side algorithms I've shown you. Thank you so much for listening. I'm looking forward to the discussion. It's great. Thank you so much, Philipp. Would you like to take over facilitation?
Yes, this was an excellent talk. Thank you very much. A quick question regarding the clinical aspect of geographic atrophy progression and the novel medications that we have at our disposal now. Do you think there will be any change regarding treatment algorithms and the load of patients?
So I think the jury is out, or I would say the answer from the EMA is out. There has just yesterday actually been a new ruling from the EMA that further postponed the decision on pegcetacoplan. So we shall see if we will have in Europe a therapy available. US has it since essentially February 2023 for pegcetacoplan. In August, Iservay, avacincaptad pegol, came on the market in the US. The adoption of this new treatment form among US ophthalmologists, at least in the American Academy of Ophthalmology survey, is actually fairly low. About 80% of the sort of retina treating ophthalmologists are somewhat skeptical towards the treatment with complement modulation. I think that's one thing. The other thing that we have to be aware of, that we are, at least with from what the media has presented and publications have presented, there's also considerable side effects with injection with pegcetacoplan, such as occlusive vasculitis. Currently, the conservative estimate from Apellis is about 1 in 3,000. And there is also the risk of optic-neuritis, which is significantly higher than that. There is also a risk of macular neovascularization induction, about 10%. Keep in mind that the study from Apellis did not exclude macular neovascularization on the fellow eye, which led to a slightly higher risk of macular neovascularization induction, more than 10% in the Apellis trials, as opposed to the Astellas trials, which ended up having slightly less than that. But the take-home message is complement inhibition with the currently available drugs in the US does induce macular neovascularization. Does it have an effect on visual acuity? Probably not. Can we treat? Yes, we can. But I think part of the question, which patients do we treat? And I think the algorithm is very difficult. I think we're very fortunate, at least here in the European Union, to have an algorithm that is already approved for market use that can distinguish fast progressors on the basis of OCT algorithm, particularly on the basis of photoreceptor degeneration. So something like that. I would very much like to give this question also to Prof. Schmidt-Erfurth, whose talks on this are very excellent. So Prof. Schmidt-Erfurth, can you illuminate us with your opinion on the technology adoption with complement inhibitors?
So we have learned from advanced image analysis that complement inhibition does reduce the progressive loss of RPE. But what we have even learned at a more intensive level is that the photoreceptor degeneration, what is visualized on OCT as EZ layer loss, because EZ layer is a term that comes from OCT. So when the EZ is lost, it doesn't mean that photoreceptors are entirely lost, but it means that photoreceptors are becoming heavily damaged. And complement inhibition clearly showed, you showed this on your graph, that the maintenance of photoreceptors is very impressive in general. That's one statement. The other statement that you also mentioned is that we should treat patients and lesions that have disease activity. Nobody would think about treating neovascular AMD if the biomarker for activity fluid is not there. In GA, the biomarker for disease activity is EZ loss, and this is what we have to check for. Then we know that this is an active lesion, which will progress if untreated, and which will respond very favorably to therapy. So what is true in other diseases is also true for GA. Identify the active lesion, treat it, and then measure the effect.
It's so much stuff, incredibly interesting. In the interest of time, I think we must progress, and I would like to announce Jay Chhablani from Pittsburgh. Boris, you said he's especially a world-renowned expert in the choroid, and now he will show us why we underestimate the role of choroid and we should put our focus on it. Jay.
Thank you so much. Thanks, everybody. Thanks for the invitation. And I'm thoroughly impressed seeing 1.6K participants, which is truly amazing for a virtual meeting. Thanks a lot. I would not be boring people with my choroidal analysis. I would really show some of the interesting cases. Unfortunately, in 7 minutes, I don't think we can go beyond 2 cases. And I will show that how looking at the choroid made a huge difference in these cases. And certainly we can get onto the discussion and further quantitative analysis, what all we can do. So these are my financial disclosure. None of them are relevant to this presentation. So just to wake up people, let's start with the case of a 33-year-old female who came to the ED with a sudden onset of curved lines in her right eye. The lines appeared curved and seems whitish and gray hue. There was no family history. The past drug history was not relevant to the presentation. She did have a history of high myopia. So the resident was called and the resident thought, okay, let's get an OCT done. And before OCT, these were the findings. She was very high myope, as we can see, -15, -16. Axial length was 27, more than 27, both eyes, 20/30 vision, IOP 17. Anterior segment seemed pretty normal, and fundus looked myopic, nothing significant. The resident got an OCT, and OCT showed a central serous kind of a picture where you could see subretinal fluid. The left eye looked all right, and the patient was advised a fluorescein angiography. Because when they have to see me, I usually ask them, get a fluorescein angiography in ICG and then show me. And I was traveling, so the appointment was delayed. So she got her FA done on 27 December, which was almost 3 weeks after her presentation. And here you can see the point leakage, which is increasing in the late phases, very much matching with central serous. These were the ICG as we expect in young high myope and central serous. Thickened choroidal vessels, as we see on these ICG pictures. These are from other fellow eye, nothing significant. That's a big hyper senescence is because of an artifact, which is again very unique with our system. So patient got an appointment with me in January, but before that, she started having vision loss and she related it with COVID, and she thought that, she developed COVID, and her visual acuity was 21/25, 20/40 in the left eye. And finally, she got to see me, which was almost a month and a half after her initial presentation. So when she saw me, she had a central subretinal hemorrhage with some macular hyperpigmentation corresponding to subretinal scarring. And as you can see here, that now you have a CNV sort of a hyperreflectivity near the subfoveal area. The fellow with me, she couldn't see the subretinal hemorrhage, considering that it is very difficult on exam sometime. But we got an OCT angio, which, as expected, showed us a neovascularization membrane, as we can clearly see on these ORCs scans. And definitely it was falling into the category of CNV secondary to CSCR. And I got an autofluorescence just to explain to the fellow that if you are in doubt of subretinal hemorrhage, you can always get an autofluorescence, which will show you a hypofluorescence, as we can see here. And here also you can see a hyperfluorescence, which could be related to the CNV membrane. This was the left eye. Left eye had nothing significant other than the myopic fundus. But I was not really convinced with this diagnosis, because in my experience, you don't develop a CNV secondary to CSC in a month and a half. So I thought, okay, let's look back into the OCT at presentation, which was 6 weeks ago. So I'm looking at this volume scan from 6 weeks ago. It does show a subretinal fluid. The choroid seemed thickened. We understand that the myopic eyes, when they develop central serous, the choroid does not really go as thick as 600 micron, as you will see in other patients. We in comparison to the other eye, this choroid was thickened, but I was just not happy with the granularity of the choroid here and the fuzziness of the outer retina, because again, you can develop subretinal fibrin in central serous, but here the fuzziness was there everywhere. And I did look into the notes from the presentation. It did not show any sort of vitritis, nothing significant. But then I started looking into the volume from the same scan, and I could see a RP breach here. Here you can clearly see that how this choroid is thickened, but there is an RP breach, and then you have some hyper reflectivity here, kind of a shrum here. Somebody could get confused by calling this as central serous with subretinal fibrin, but I was still not convinced that why there is choroidal fuzziness there, because in CSC, you will see thickened choroid, but why there should be a fuzzy choroid? And I started looking back into the angiography pictures. And if you really look carefully on angiography, you really don't see these point leakage, what we expect on CSC. But not only that, look carefully, there are few more hyperfluorescent spots away from that main leakage area. And if you really look into the later phases, it really does not correspond to an ink blot leak, but actually corresponds more to the inflammatory kind of a leakage. And that's where we started looking into the different possible reasons. And I diagnosed this case as CNV secondary to PIC, which fit into accurately into a young high myo female, which is more prone to develop a PIC. And I diagnosed this case as a CNV secondary to PIC. And the initial presentation was actually PIC, which started resolving on its own, but eventually ended up developing a CNV, and that is where we had subretinal hemorrhage at presentation with me. So then we looked into the literature, and it did show something called as sponsine, which is present in patients with PIC, which is what was there in our patient as well. And here you can see very clearly that how the choroid is taken only in the one segment corresponding exactly to this literature case where they treated this patient with once this lesion started resolving, and after anti-VEGF therapy, the choroid started becoming thin. And this is what we did. We started the patient on Avastin. This is picture after one injection. Here you can see that already the lesion started regressing, and I gave her one more shot. And after 2 injections, you can see that the choroid has gone back to normal. The lesion has luckily regressed completely. The subretinal hemorrhage has regressed, and she's back to 2020. So I would say that, see whether it is CSC or PIC, most of the time the condition is self-resolving. But what made the biggest difference for me was that why the choroidal reflectivity was so hazy, the choroid was thickened, which can again be there in both eyes, both conditions. But I think the more important learning was that you need to start differentiating whether it is an inflammatory thickening or it is just a CSC related thickening. And again, remember that in myopic eyes, you will not have a significant thickened choroid, but compared to that's why looking at the fellow eye helps. And compared to the fellow eye, there is clearly a thickened choroid, and you have to start looking into the inflammatory signs, what we could see in this patient, looking into the FA as well as OCT. Let's get on to the second case. Because of time, I'll not be able to go beyond a second case. So this is the patient who presented to me in September 2023, 36-year-old female. She had been having poor vision in the left eye for last 4 to 5 years. She was receiving injections, and she said the injection were doing good, but then she was pregnant, and because of that, she had to stop the injections. So before she came to me, she stopped injections in 2019, and now she has 20/20 in her right eye, left eye hand motions, and this is what she came to me with, where right eye looked all right, but if you really look at the left eye, you will see that there is a lesion in the peripapillary region, which could be secondary to CNV. There is a subretinal scarring, again, understandable, long-standing, not treated CNV, which became scarred. And this has started affecting her foveal area as well. And here you can see the autofluorescence, hypoautofluorescence due to scarring, a slight hyper in the periphery, again involving the foveal area. And this CNV clearly is seen as scarred, and you can see chronic cystoid changes affecting the fovea, and which is understandable. But I was wondering that it is very important. I always tell my fellows, don't make the diagnosis of CNV, because CNV is not a diagnosis. CNV is a finding. Always try to find the cause for CNV before you start any injections. So we were wondering, what are the thoughts into the causes of CNV. And this is a table from one of our publication where we showed that different causes of peripapillary CNV. And this is a long list. Let's look into her scans coming from 2016. So 2016, this patient came to the ED with onset of anisocoria. Patient was seen by neuro-opht. Then they saw, oh, there was some myelinated nerve fiber with anomalous optic disc. She was diagnosed to have Eddy's pupil, went to see a retina specialist. They got an OCT done. They saw, oh, there is some fluid on the nasal side in the left eye, and they diagnosed as peripapillary CNV. Patient was started with anti-VEGF. 2050 was the vision, which improved to 2025. She was getting regular injections. Everything was going great. Then she started deteriorating. Probably the CNV was not responding to anti-VEGF, and patient was continued on anti-VEGF, maintaining 2050. In 2020, when she came, she was pregnant. The CNV had enlarged, the vision started deteriorating, but because of pregnancy, she could not be treated and then got lost to follow-up. So now she's back again where we saw in 2023 with me. But now when we really look into the causes, I looked into the OCT scan here from 2020, which was really a great scan. And here you can see that the choroid is thickened. There is some like kind of a spongiform changes in the choroid, which shows I could not see the outer border of the choroid, though the scan was so good. Here we cannot differentiate choroidal structure itself. And that is where I think the pathology was lying. And this is where I got a B scan done at a visit with me, and which made the clear diagnosis of choroidal osteoma. And we diagnosed this case as CNV associated with choroidal osteoma. So then we treated we decided not to treat this patient. I think because of lack of time, I cannot show more cases, but I have some very important take-home message is that whenever you are looking at a scan, just look into the choroid. There is something lying there which will help you to make the diagnosis. Thank you so much for your attention.
Thanks very much, Jay, for this long case presentation. That's, you know, often all of us have cases like this where basically they've been coming for years and we've been treating them for years, and then, you know, all of a sudden you find, oh my goodness, there is so much more to this. I mean, I was really puzzled with your choroidal osteoma case. I would have even thought this could even be like a choroidal hemangioma, at least from the appearance that it had to some extent. I'm sure you've had angiographies. I've had a quick question for you. So, you know, punctate choroidopathy, relatively easy to treat disease. There's some discussion at the moment in the literature suggesting that these patients should be managed also with systemic steroids. What is your opinion on this?
Yeah, I think this is getting more and more controversial now that we have much advanced imaging. So I would say that unfortunately, most of these PIC cases, they come to us late by the time they already have healed. So if I don't see any fuzziness at the borders, if I don't see any activity on the angiography, I usually don't treat them. But if they are coming to us at a very early stage, I would also prefer to put them on steroids. I really don't know how much benefit are we getting by giving them steroids, but having the discussion, and if the patient is on board, I would also advise them to start steroids and see how they heal, and if they heal better or a better scar. Yeah, that's my thought.
Okay, thanks very much. Okay, so I think in the interest of time, thanks very much, Jay, for waking up early for us. It's been a great pleasure to have you.
Thank you.
We should move forward with the program. I mean, this is now going to be followed with two of our gold sponsors, and I leave Peter for the introduction.
Ja, sehr schön. Sascha Fauser, magst du beginnen?
Sascha Fauser, do you want to start?
Thank you. Sascha Fauser, would you like to start?
2 minutes for the industry.
Well, welcome.
Wo können wir denn besser werden?
2 minutes for the industry. Where can we get better beyond anti-VEGF in treating neovascular AMD? Many things have happened. What can you tell us, Sascha Fauser? Thank you so much. My answer is our research concept in 2 minutes, so to say. And we have seen that with the anti-VEGF therapy, we really have reached a lot. We have come to an end, so to say, in anti-VEGF, and it does not help so much. And basically, neovascular AMD and also diabetic macula and also venous closures, for example, they are multifactorial complex illnesses. And it's quite clear that if you neutralize one cytokine, for example, you cannot sufficiently treat all the diseases. And we are therefore systematically working on, apart from the VEGF, to work on other mechanisms and to use them, VEG plus, for example. And what we are working on is bispecific antibodies. And here on the slide, you can see Vabysmo, but I can explain it a bit more. You can see that one arm is here in yellow. It can bind one molecule, and the second one can bind the second molecule. On the one hand, we have the VEGF, and on the other hand, we have the angio 2.26, for example. We have more than 2.5 million injections or syringes worldwide. We have very good studies, and it also shows that we have done 5 real-world studies. For example, we have a very long durability and very quick drying, for example, of retinal fluids. So we want to use more ingredients and agents, for example, and we also want to offer more options. And of course, also in ophthalmology, it has started to be successful. A very short answer, for example, if you have Ang2, for example, is that going to become a game changer in pigment epithelia detachment, or are you going to say that it's a classical mechanism drying the whole retina, but hopefully with a better efficiency? What do you say to that? It's hard to answer, and it's a very specific, and we have to find out whether it specifically works in this direction. But I think we have a better stabilization of the vessels that we can reach. The angio 2.26 also is an inhibitor, but it might also inhibit other things, which is very important for homeostasis of the vessels. Thank you so much. And now Ms. Lorenz is going to tell us about clinical efficiency. Ms. Nietzsche also is here from Bayer. Welcome to you, to Anna Nietzsche. Of course, also you have brought along an answer. Have you seen the VEGF to also defend VEGF as a big pillar, oxidative 8 milligrams, for example? That's in clinical everyday treatment, the aflibercept 2 milligrams. Is it still used or not? Thank you so much for the question, Professor Schurman. And I hope that you can see my screen that I'm trying to share. Well, indeed, all in aflibercept 2 milligram, we look at well-proven products that have addressed the AEs, for example. And since it has been approved more than 11 years ago, it's the gold standards when treating retinal diseases. And until now, in no study, for example, it was not superior to 8 milligrams, and also with 2 milligrams, for example. With long syringe intervals, for example, you could treat them, but with 8 milligram, of course, we could increase the share of all of them. And that was also very important. And due to a quick drying, the aflibercept 8 milligrams is a classical therapy and also reduces, of course, the treatment burden of the patients. And here you can see very clearly, and if I click on to the next slide, here you can see the treatment internals, and you see the heat maps. to the left, the approval study of 8mg, the impulse heat map, you see each and every line, which represents one patient. And you can see that after a 3 months upload, for example, in 12 and 16 weeks treatment, the patients immediately have put on the mode and they could even be prolonged. That means for the patient that they only get 2 to 3 syringes per year. And in this heat map here by the photon study, 90% of the patients got the treatment interval in the second year. That could even be prolonged even more. So with aflibercept 8 milligrams, we are also trying to follow up on innovative solutions for retinal diseases. And of course, we are working a lot on, for example, having a syringe ready and the approval for aflibercept 8 milligrams for retinal vein exclusion. We are also waiting next week. And for example, in youngsters and in early births, for example, 2 milligrams will be important, but for all the other patients, we will make available 8 milligrams. That's a very clear statement. Thank you so much for that. Well, indeed, there is this shift to the new medicines, the new drugs. I would like to thank you so much. And now we would like to continue. I mean, the break, so to say, that has been our buffer. So to say, of course, you can take a break anytime, but not now, because now we will hear the very interesting talk from Privatdozent Dr. Philipp Roberts, and he's going to all about intraretinal cysts. And as Drusen are not Drusen, intraretinal cysts are not only cysts or not the same. So Philipp, the floor is yours.
Fantastic. I hope you can hear me. Well, I would like to talk about the macular edema. What is this? It's just a swelling of the macula due to subretinal fluid or intracellular fluid. Intracellular fluid, so diffuse swelling of the retina, or due to an intercellular fluid, and that's what I will refer today, so-called cystoid macular edema, CME. And we call it like this because that's not really real cysts. So it's a kind of a wall of cysts, but that's not the case with the retina. So that's these spaces of fluids and how they communicate to each other. So you have this representation of these extended cells separating them. That's how it appears typically, the cystoid macular edema. So this accumulation of fluid in the inner and outer area, and that's a typical centropetalrenal pattern. So this structure of the cysts directly on the fovea. And considering the pathogenesis, if you want to understand it better, let me explain a little bit the anatomy. Well, you have this intraocular pressure. That's why constantly there is some fluid pressed through this body, and the retina gets dry and thin or transparent only because the fluid follows the osmotic gradient. And on the other hand, there is an active pumping mechanism. That's quite important to know and understand. And considering the retinal anatomy, then we can see that there are 3 different layers on the retina. Well, here you can see it in a very beautiful way. There are 3 layers where the fluid is gathered, accumulated. It's always the ganglion cell level, the outer inner level. So that's where we have cell bodies, and they will be separated by the fluid. That's the layers here, where typically cysts can be found. But I call them cysts, nonetheless, the fact that they are not really cysts. But then there are 3 typical barriers inside. So the inner plexiform layer, the outer plexiform layer, and the external limiting membrane. If all these 3 layers work correctly, then the cysts And that's always the case. And if you consider it, if you consider the plexiform layers and as well as the external limiting membrane, what are they? So they are basically the synapses between the cells, and that's why there is no space for the water. So the cell bodies are separated. And here you have a clinical example. That's an example of one patient. He has a cystoid space, or he has this edema, and you can see that the cysts are accumulating in these barriers, and the fluid respects these barriers. So you have the three layers mentioned right before. They are quite good barriers. And then there is another important factor which is important to understand all this. So the retinal vascular supply, and we learn a lot about OCT and so on. We know that there are three different layers: surface, intermedium, the last one, SCP, ICP, DCP, and we know that at the surface, this arterial, and the deeper you get inside, the more it will be venous, referring to the fluid, and that's why the interretinal fluid is following this and gets from the surface inside. And well, these cells play an important role in the transportation of the water, accumulating the fluid from the retina and transporting it downwards inside the system. And we differentiate two important types of cystoid macular edema. On the one hand, the vasogenic one, due to a breakdown of the blood retinal barrier. Well, there is no fluorescein leakage in this case. As for the sources of the fluid, maybe that comes directly from the retinal circulation. And then you have the creation of the cyst, or you may have a choroidal circulation. Then the fluid is coming from the bottom, from downwards. And if you have a barrier, then you may not have the cystoid phenomenon. And here I selected a clinical example showing quite good this vasogenic cystoid macular edema. You can see this occlusion, a branch retinal vein occlusion, and the ELM disruption, excuse me. So, well, the patient responds positively to the first injection. A couple of months later, he comes back. So the phenomenon increased. He gets one more injection. It decreases slightly, and you cannot see it here on this image. But here, considering this extract, that's the beginning of the end. There is a little bit of subretinal fluid, can be seen there. You can see that the ELM is not intact, so there is not longer this function of a barrier. So the fluid can pass through, and what you can see as well, vertically, there is a vertical hyperintensity due to Müller cell, the appearance of Müller cells. And if you observe this during a couple of months, you have more and more fluid. The pigment epithelium hypertrophed. So the system tries to reduce the level of fluid. And if you consider this, now here you have a new type of cystoid appearance. Well, that was the vasogenic type, but there is as well the non-vasogenic type due to cell dysfunction. So the blood cells. So here we have the cells coordinating the transportation of the water. So there is no leakage basically, and the sources of fluid are vitreous or the retinal metabolism. So it's due to this metabolism because the retina is very active, has a very active metabolism. that may be due to drug toxicity. This may tractional, as you can see here, with this kind of membrane, mechanical tractional. Here you can see the cysts as well, but typically always on the three layers I mentioned before, or inherited dystrophies, or yeah, there may be an acquired RPE dysfunction, as you can see here. That were just a couple of different examples. And as a conclusion, I hope I could show this phenomenon that these cysts like gathering and accumulating on the same layers. We distinguish vasogenic and non-vasogenic. You should always have a look at the structures when you want to detect the cause and the origin, and that might be helpful for your treatment. Well, thank you very much, and I'm looking forward to your questions and comments.
Yeah, ganz herzlichen Dank. Many thanks,
thank you very much,
Philipp, for this fantastic overview on causes for macular edema or cysts in the retina, more specifically. I have a question. You know, sometimes we have these patients who come back from an ILM peeling and they have this what looks like very small cysts in the retina. So what do you do with those? Did you see those as well?
That's an excellent question. So sometimes that is very true. After an ERM peel or after an ILM peel, you will see, especially in the inner nuclear layer, cystic formations. And the hypothesis is that this is a Müller cell dysfunction. So essentially, by peeling the ILM, you're taking away the basal lamina of the Müller cell foot plates, and which obviously doesn't make them very happy. So in the beginning, you will have cyst formation in the inner nuclear layer because the Müller cells don't function very well anymore. And later on, after a year or so, you may even get atrophic changes or at least a thinning of the inner nuclear layer, the inner retinal layers, which is very common after retinal surgery.
That's a question from my side. So how do we handle these fluid volumes within the retina? Because we know that it's intraretinal fluid that has the negative impact on vision because the photoreceptors will be destroyed or are already destroyed. So if we see these different types of intraretinal cysts, we can reason about what the origin is, but what would be the therapeutic reflex?
That's also an excellent question. So obviously, depending on the origin of fluids, so if you have urban gas, for example, or pseudophakic cystoid macular edema, then you would rather treat with anti-inflammatory drops. But if you suspect a vasogenic cystoid macular edema, the most common causes would be diabetic retinopathy or retinal vein occlusions, then anti-VEGF would, at this point at least, be the first go-to medication.
Anti-VEGF therapy in diabetes-induced intraretinal fluid doesn't work that great. So compared to CNV, the intraretinal fluid in DME only disappears in maximally a third of the patients, which is entirely different from fluid in neovascular AMD, where one injection already takes care of all the intraretinal fluid, except if it's of degenerative origin. So hard to say. I think it's always a little bit trial and error with therapy.
That's an excellent point. And especially in diabetics, anti-VEGF treatment sometimes takes many, many injections to actually work. And now with the new Vabysmo and other treatment modalities, we may have new possibilities. So thank you very much for your question.
Very well. So in the interest of time, ist es nun eine sehr große Ehre für uns, Frau Professor
It is a
Schmidt-Erfurth.
great honor for me and us to ask Mrs. Professor Ursula Schmidt-Erfurth in order to give us an overview on new biomarker therapies, protocols of supervising and treatment. Thank you very much for coming. We are looking forward to your presentation.
Thanks for the great introduction, and the honor is completely on my side. I hope you can see my screen. Yep. Okay, so I was asked to talk about biomarkers for the therapeutic monitoring of retinal disease. This is something that, of course, we are dealing with at a large extent, but is a great challenge. I mean, so many million of people we have to keep in mind that are probably older and aging more and more, and where we have the probability that a retinal disease and a macular degeneration is going to develop despite all our intensive efforts in retinology with great diagnostics, for example, and great medicine in the past 20 years. Nevertheless, the probability to lose the visual acuity has increased. This has to make you think. And what also personally made me think when I read many places that geographic atrophy, for example, were very slow courses of the disease, it might be until practical blindness, so to say. But if you read that 2/3 of all the people affected within 1.5 years, they lose the eligibility to drive a car, for example, someone who does not live very close to a train station, you look at it from a different point of view. So treatment and diagnostics is a great effort and a great task. And we know all the standard examination methods for retina experts, dozens of times per day we look at that. And it's a great effort. And if you only have to look at these videos, for example, of course, a lot of conclusion or information that simply passes by. Information is important if it comes through biomarkers in the neovascular, for example, AMD. We have a very clear biomarker, which is fluid at the start of the clinical disease and also the beginning of therapy. Fluid. You can see it all mixed around in a 50 Shades of Grey video. And what we have long understood, for example, is that there are 3 different types of fluids in the retina, under the retina, and what we also have heard, thankfully, under the pigment epithelium. For that, we need to find a solution that prevents that the doctors spend many hours of their time looking at gray shades videos, which is a fluid monitoring. And the fluid monitoring is a pool where you see the image of your choice and you simply upload it into the cloud. Out in the cloud, this is a server, and this is where an algorithm works with all the pixels and all the images, and it can filter out very well which fluid exactly is there and how much fluid we have exactly at which point in time. And this is what we need if we want to work exactly. And that, of course, affects us all because the retina and the macula, they are unforgiving. So we want to be as precise as possible in our diagnosis and the therapy in order to avoid damages. This is the alternative concept that we have. And the solution, the problem is only to watch or to look at videos. That's not going to solve the problem. We need a good evaluation of the spectral or another device specific or substance specific apparatus, and we don't have them at the moment. Here you see below the B scan and how the fluid has been noted. The algorithm has done it right. The image quality is high. So here you look at the three en face images where we have intraretinal and red retinal in yellow and pigment epithelium fluids. That's very important to distinguish them because whether it's the central focus or whether the perimeter. And also in course of time, you can see the spikes and waves. So this is the individual biography of the disease activity in these specific patients. And apart from that, you can see from visit to visit, for example, you see whether you have more fluid or less fluid. Do I have to treat? Do I have to make the interval shorter, for example? It's lots of information without having to lose much time watching videos. And this information you can also give to the patient, and you also can do a documentation and put it to the patient's record. It's different from what we're doing at the moment, where you have to put in manually more fluid after different treatments. This has a big effect, of course, also on the productivity. This is one of the early users in the normal clinical practice, for example, that the cloud-based tool, of course, has a full certification. It's the only tool which is MDR certified, which is the toughest certifying regulation body. The fluid monitor and the GM monitor only have that, as Vincent Gualino has that, who has very good clinic, and he uses this tool, and he has tried it with more than 5,000 patients, and he said that now he can do a diagnosis to 26 patients in a way that he can rightly treat them. Oh, well, that was in the past 26, and now it's 40 patients today that get medical treatment. This is not only more productivity for the doctor, but also for the patients. The central retinal volume is always used when we talk about clinical studies. For example, how long can I stop treatment? When do I have to take up treatment again? If you have a systemic, the central retinal signals, what they really measures compared to the real fluid, the correlation, for example, in neovascular retinal degeneration is very low. So there we don't get much information of how much fluid we really have. And that does not tell us when we should give the next injection. Intraretinal fluid is different from the other two types because the more intraretinal fluid, worse the visual acuity is going to be. In subretinal fluid and also the PED, things are different. But it's also very clear that the intraretinal fluid makes your visual acuity worse, even if it's only a few nanometers, the photoreceptors are destroyed. Here you can see that when we work with another automatic algorithm, the photoreceptor thickness and also the loss of photoreceptors. We have measured that, as you can see here on the slide. And as expected, you see that intraretinal fluid also, if you have a higher amount of them, it destructs the photoreceptors, and that leads to an irreversible loss of visual acuity. It's quite interesting. If you look at the right, for example, you have the PED attachments, for example, and even if they are increasing, they also destroy photoreceptors. So, Mr. Stanzler, I think you said that the photoreceptors, this is something that you have to look at because, yes, it has an effect on visual acuity. These is all regulatory approved, for example, spectral machines, for example, if you don't have the latest software of Heidelberg HVI6, for example, you can use a separate computer in parallel, and immediately all the results are uploaded in the cloud, and after a few seconds you can also print them out. And it's a big difference whether you look at a video, for example, together with the patients in the darkness where the patients can't see anything, or whether you can look at the results when you have enough light, and this measure is super correct, and the square, the IRF square is 0.996. So there is no question whether that's a good measurement or not. That's beyond any doubt. In geographic atrophy, you have another important biomarker, and that is from recent time, which is the EZ loss. We said the EZ loss is a term that comes from the OCT imaging. This is the line that is above the RPE. And here the mitochondrial leaf fold cell bodies are shown in the outer segments of the photoreceptors. This EZ loss, 10 years ago, we did not know that it might be relevant. Now we know it. And due to increasing evidence, we see that there are functions also located there, and also in FDA, for example, that the finally outcome markers for atrophy are affected. The crux in geographic atrophy is that you cannot see that because the neurosensorical damage is below, as Mr. Stanzl also has said in his presentation. So this change takes place at photoreceptor level and OCT, the EZ layer in the RPE. What's interesting, if you do a follow-up on that, how geographic atrophy comes up, it's a long process. It takes time, and is a certain order of things that happen. That is always based on an outer nuclear layer and the photoreceptors, for example, that 5 months before the first clinical proofs are deteriorating. That shows us that we have to do therapy. If you are first, the Drusen are collapsing and hypertransmission, those two happen at the very end. If a big damage already has been done to the upper photoreceptor layers. Photoreceptors are very hard to visualize. For more than 10 years, we have done optimization, and validation to bring together an ensemble for an algorithm to make sure that the algorithm can show the EZ line to show the pixels, and 1 pixel is 4 micrometers, for example. For that, we have done many validation tests and tools, and also reproducibility is very important. So we took various images on different days, and in green you see what's right, and in red you see the deviations is less than 0.15 millimeters, and the dye score is very high. Of course, you need a very good retina experts to work through all the base scans. It would take 7 hours, for example, to really be able to show GA on such photoreceptors. The interesting clinical learning, that's why these huge data in clinical studies are not only super interesting for the industry, but also for us clinicians. If you look at the course in time, for example, how a full-blown geographic atrophy comes, that is shown in blue, and it's increasing, but only where the photoreceptors are already destroyed. I mean, not dead, but heavily affected. And you see in all the images, and in 2 years, untreated patients, we see that very clearly. So first, the photoreceptors are disappearing, damaged, and after all, the RPE is going to collapse. So we can also predict where the damage is going to be done. And the retinologists, they love it to see things with our own eyes. The retinologists love that. If we have a spectral OCT, for example, and we put it in the GA monitor, we upload it in the cloud, and within a very short time, we see something that you usually cannot see. I mean, you can see the fluid and the bubbles, of course, that is something you stumble across, but not the loss of photoreceptors. This GA monitor that everyone can get. If you want to use this algorithm, get in touch with RetinSight or Heidelberg. It's a spin-off of my clinic. Of course, I am particularly proud of that. And here you can see in blue the RPE defect that would be black, and the fundus autofluorescence And what you see in the fundus autofluorescence is not the damage to the photoreceptors, that is shown green. And if you put both things together, you see exactly where the tendency is going. And with photoreceptors alone, you cannot do that, but above that you see the progression, for example, and whether a therapy was helpful to stop or at least detain a further deterioration. That is not only cool, but other key opinion leaders like Bob Avery says, for example, the clinical decision making that is needed for GA, because of course GA, geographic atrophy, of course, we want to include it in normal OCT management that we do, and not only want to buy fundus autofluorescence cameras. In the comparison, you see where you have a big green zone, you have a large growth. This is a video over 2 years. To the left, there is nothing, but because there is no active peripheral zone, and you can also show it in cortex. Quartiles, for example, at the bottom, you don't have a grain and a very quick transmission, and the patients have to be treated. Now, what happens with treatments? Treatments, of course, we also see it from the graphs that we have seen. The treatment inhibits that the loss of photoreceptors as increasing, and you have the fellow eye to the left. And we also see to the right on the study eye, the loss of photoreceptors remained but smaller. And this is what I would call a therapeutic benefit. You can also see it in the graph, for example, the RP-RP quartiles, blue and green, photoreceptor compared to RPE ratio, for example, how much green part do you still have left? If it's big and getting bigger, you have a big therapeutic effect, and you can see it in 4 quarters. You see sham is in gray, and with a lot of certainty, be it monthly or bi-monthly contra inhibition, you can also reduce a lot of deterioration. Such AI-based OCT tools are extremely helpful for clinical practice, also for clinical studies, because they are real-time. As it's such a precise algorithm, it does not have to be readjusted or corrected. If you look in literature, there are some algorithms, for example, who have offered something similar, and then to your disappointment and honest speakers say it's semi-quantitative, so it has to be corrected afterwards. With that, you cannot bring it into the clinics, because you can only bring something in the clinics which does not have to be corrected afterwards, which is 100% safe, which can be uploaded and downloaded immediately, so that I can give a treatment to my patients and that I can explain to my patients what their problem is. Another point, the last point, which I consider very important, because we read in the papers 5 million people, for example, are affected by geographic atrophy, 5 million. It's a huge under diagnostics, because many patients have been lost or come too late. There are many, many more people who have a geographic atrophy, which is outside the center and does not make the visual acuity worse. Of course, we have to concentrate on the individual patients as ophthalmologists, but they come from a sum of a big chunk of population, and geographic atrophy is the most habitual part of GA. It's not only 5 million, it's much more. So if we have such an OCT that every scan of the retina can be made, that might also be great to detect patients who do not know how close they are to losing their visual acuity, for example. You see, for example, in these patients that these patients still have visual acuity, but his macula is highly damaged, and they have highly progressive forms of macular disease. And Mr. Chancellor, also you have been the one who mentioned it before, because you have had such a close look at so many things. Many patients already have lost photoreceptors, even if it's only small isolated effects that we see, but we want to see these patients. We want to be able to treat them, and we see it automatically if in every intermediate AMD, for example, a geography scan would be done. And you would wonder how much patients could be treated at the right point in time. You would wonder about that, because there you could still keep the visual acuity and save it in the long run. So this monitoring is very important, that screening monitoring is very important, and the FDA also shares that, and that the EZ loss has become a really important marker. You can only see it in OCT imaging, and you can only see it if an algorithm finds it. Now we live in times of full automation, and that we can get support for our diagnostical work, that we can do it everywhere and at any time, because through the cloud you can get all the information in real time. We don't have to spend 7 hours to look through all the B scans, for example. And we have a ready-made result that's very important for fluids, that's very important for geographic atrophy, for clinical trials, for visual acuity, for example, for GA, and we have to make sure that our budgets are rightly allocated and that we invest in the right things, so that the ophthalmologist and also the resident physicians, that they get the important things, because we do not want to lose time. We have the important task to care for millions of patients.
Thank you very I'm sorry. Apologies. So thank you very much for changing the love of ophthalmologists for the shades of gray to changing it to love for color with artificial intelligence. I think your talk has really beautifully illustrated the perhaps speed up of some of this tedious analysis. Because we have Thomas Ach in the forum still with us, very grateful to that. I'd like to give the word to him, because he is in the clinic of Frank Holz, who clearly also is a major key opinion leader for geographic atrophy. And I'm aware that they also have developments for artificial intelligence algorithms. I'd like to have a bit of his sort of view on things of perhaps just see what they're boiling under their hood. Thomas, tell us a little bit from your world.
Of course, we have. There's also a reading center here in Bonn, and they are actually working on some similar kind of algorithms to automatically detect those lesions. And as mentioned by Professor Schmidt-Erfurth, I mean, this is one of the key aspects of future analysis of such huge data load. So I'm not saying one algorithm is superb over another. I mean, there are always advantages and disadvantages, but in the end, it definitely helps us using all these artificial intelligence and these methods to speed up the time of analysis. And I think that's a huge advantage of our current software development.
I'm very happy to hear that you are switching, because fundus autofluorescence was always the passion of your group, and fundus autofluorescence doesn't show us photoreceptor damage. And I'm very much looking forward in the near future to see something from your side.
Well, it's not only about autofluorescence. Of course, autofluorescence is a marker for RPE cell health, and we've learned in the past that when autofluorescence changes, but in both ways, so it's hyperautofluorescence or hypoautofluorescence, it has something to do with changes in the retinal pigment epithelium. So I still believe in this technique. We're doing a lot of basic research to understand how RPE changes. But of course, the current data showing that photoreceptors or other retinal layers or the first layers that might change in AMD, that's interesting stuff. But I still believe that RPE has something to do with it too.
It definitely has something to do with it, but the patterns, for instance, the FAF patterns, banded, trickled, and many words do not reflect disease activity as we could show, and that will be presented at ARVO, and I hope you come for a great discussion.
Yeah. I'm so grateful that you have clarified that the future is not coming, but the future is already there. And just to clarify it, we've inaugurated the fluid monitor in our consultation about a year ago with your help, and we're very grateful for that. And we use it currently in 100%. On the one hand, of course, it's under study conditions. You can argue maybe it's only necessary for very special cases. On the other hand, we have the impression that even in simple cases, about 20% of our cases, the fluid monitor has a different and more exact diagnosis compared to the central retinal thickness. So do you recommend to use a fluid monitor in all cases? So completely? Our consultation is now not the macular consultation. We changed the name to KI, so artificial intelligence consultation. But I'm still not, for me, it's not clear if it's really necessary to use a fluid monitor in all AMD cases or just in a selected part of cases. What's your opinion?
Well, it's a mouse click, it's a regular OCT, and it's advanced technology. So why not use the best what is available? And whether it was worth it or not, you can only tell when you have the result and can compare it to CRT, but CRT is not a value. That's just a random cut, and it cannot give you the full amount of fluid. And of course, you can tell that there are a few bubbles in an OCT in the video. Most doctors, as polls show, just look on a central B-scan printout, and that does not give you the full picture. So you have to go through a video, you have to compare to the previous one, and it is impossible for even extremely intelligent and trained eye doctors to have an idea about how much fluid is there. Is it more? Is it less? Does it matter whether it's more or less? Yes, of course it does. If pigment epithelium increases in size, in volume, that means then the photoreceptors overlying it will die, and a month later there will be intraretinal fluid because the barrier is damaged. Intraretinal fluid, cystoid fluid, you can have a lot of bubbles, or less bubbles, but some of them will never go away, and you can just measure whether the fluid amount in the retina remains the same. Then you don't need to treat them because we know it's degenerative. Subretinal fluid, yes, if it's flat and little, then it will, in addition, nurture the overlying photoreceptors. However, if it's expanding and becoming higher, and that is not seen in the central millimeter, it's always outside in the 3 millimeter area, then vision will drop. So I think there are good reasons in medicine that we like to measure things.
Okay, I always love to listen to you. So I'm very happy that you have been with us. Thank you very much.
Thank you.
Okay, so Philipp, you might announce Anna-Theresa.
So our next speaker will be Anna-Theresa Lorenz, who is one of our excellent residents at the eye clinic in Sulzbach, and she will be talking about diabetic retinopathy.
So, vielen Dank für die Einführung.
Yeah, thank you very much for these introduction words. And thank you very much for the opportunity to address the audience and to intervene in the frame of this conference. So, what to look at for an OCT in diabetics? We know that the diabetic marker edema is one of the most frequent reasons and problems, and currently, so we use. We want to know if there are other predictive biomarkers. If you have a look at these two patients, and then we can see that here, as for this patient, the central thickness of the retina is much larger but with the and in addition with the better visual acuity. This means there are other biomarkers to be used in order to assess this. And I would like to present some of them. On the one hand, the ellipsoid zone integrity. So that's a post-hoc analysis of the VISTA data, analyzing the weakening or the decrease. Here you can see three overviews showing different thicknesses. It's like a kind of a topographic land map. According to the thickness, you see different colors. Here you can see the thickness of the central retina thickness in the middle of the from the ellipsoid zone up to the RPE, and here at the end the interregional and subregional fluid with its corresponding V-scan. If you have a look here, when we zoom in on this scale here, we zoomed in, this is enlarged, and that's why here you can see the thickness of the ellipsoid zone up to the RPE. And over these 2 years, this is increasing. And if you have a look at this more in detail, what are we looking at from the ellipsoid zone up to the RPE, the thickness, not only the ellipsoid zone, but as well the outer segment. Basically, so the thickness of the photoreceptor zone. And if you consider this increasing, and you can see how the course evolves, and this is coded in different colors, as I said right before. Having a look at the B-scan in order to get an overview, here you can see that right at the beginning, the ellipsoid zone is not really segmented, but at the end of these 2 years, we can see it much better. Here you can see the entire segmentation. Now the question is, this parameter, the volume of the EZ up to the RPE, does this correlate with the visual acuity? And as for this, we can say yes, absolutely. We can say at any moment of time, this correlates to the visual acuity, regardless of the volume of fluid. And we can say that the thickness, this is a quite good biomarker for indicating the loss of capability of the photo sensors. And as you can see here, the mean thickness is difficult to conclude about the thickness here, as you can see here, volumetric OCT, angiography, scan map, and a patient suffering diabetics. What can he support? So if we have a look at this, the inner retinal layers, well, in this study, we had 3 different treatments. A patient here in blue, and as for this patient, well, the therapy has been based on the visual acuity, then a diabetics, once laser, and here a second diabetic only observed. And as for these 2 last groups, they only have been treated once it has been seen and stated a decrease of the visual acuity. And if you consider the course of 2 years, then you can see that at any moment, as for the visual acuity, there is not really a big difference as for the visual acuity. This means you just can do therapy, and only if the visual acuity is decreasing. So, well, here at the beginning, the visual acuity was quite good, and we know that a diabetic patient tolerate a lot of fluid before decreasing visual acuity. But does this mean that fluid equals fluid, regardless the amount and volume? Let's have a look at the intraretinal cysts. So this work group checked different biomarkers and analyzed these biomarkers. And we know that the visual acuity is not a good marker for the relation of structure, the ratio between structure and function. Here we can see the medium analysis, and as for this, here you can see the numbers. Same thing applies for the INL cysts. This means in addition to the recommendations or regarding the therapy criteria, we can say that we shall treat and only treat if there are cysts in ONL as well as INL. And as for my last biomarker, so the epiretinal membranes, so what did we consider here? Well, here we checked how the behavior changed or how the retina changed, and in addition, or according to this, we had an improvement of the visual acuity. But we have to be careful. So this example shows it. This patient here submitted to an ERM peeling, and 6 months later of monthly anti-VEGF therapy. You can see this OCT here, complete atrophy here, along with a loss of visual acuity. Well, we checked this. How about the OCT? Baseline 6 months later, enlargement of deep CFZ after peeling. Here you have the deep papillary plexus, and 6 months later you can see that here the zone free of capillary post-surgery after 6 months, this increased significantly. So diabetics patients having already a problem here, they react in a very sensitive way to this peeling and the damaging of the Müller cells. That's why, as for the diabetic patients, peeling should be done only in certain cases. If there is a worsening of the visual acuity, and even then I really have to address the issue along with the patient and have to explain it to him. And summarizing it all, CST alone, so that's a rather poor biomarker for visual acuity prognosis and the guidance of treatment regimen. So ESAT integrity, biomarker for the dysfunction of photoreceptor, large cysts and cysts in the inner nuclear layer, so should be treated, and epiretinal peeling for diabetics only if there are strong tractions. And an ILM peeling for diabetics, if possible, should be avoided. Thank you very much for your attention.
Thank you very much, Anna-Theresa, for this fantastic quick overview for diabetic macular edema, new biomarkers. At this point, I also am grateful to see that Andreas Pollreisz from Vienna has joined the group, and I'd like to go back to your slides, if that's anyhow possible from the technical moderation. So you showed that basically in the EZ analysis or the outer photoreceptor height, that basically when in the post-hoc analysis of VISTA with aflibercept 2 mg, basically in the first year, there was essentially continuous EZ integrity loss, and it was only basically from month 12 onwards to month 24 when the EZ was intact. So is that correct? Did you see that?
Yes. So it was especially in the first year we have change in the thickness of the EZ integrity, but after the first year of treatment, when we compared with the second year, it's like stable. I tried to share again. And we can see the slide. Okay.
Just a moment, sorry.
Jetzt müssten Sie teilen können.
Yeah, possible. So yes, this one. So during the first year of treatment, we see that the thickness is changing, but after this first year, and when we compared with the second year, it's like stable, and also the CTS.
Okay. Yeah. So that might perhaps to some extent explain perhaps the clinical trial design of Photon. At least it appears to me, because Photon essentially in the first year did not pre-specify as their treatment modifying regimen any CST as any absolute CST value, but only CST change as basically a criterion to jump between the intervals. By contrast, basically Yosemite and Rhine from Roche actually had pre-specified a sweet spot of 325 micron up until when you would have to do your injection in the sort of maintenance after the upload. But you know, because we have Andreas Pollreisz, who is the head of the diabetes clinic in Vienna, I'd like to have his take on this, perhaps clinical trial design, what he feels perhaps is relevant here.
So you're referring to the 325 micrometers from the phase 3 trials. I think this is quite a high threshold, to be honest. And in post hoc sub-analysis, they kind of reduced it for certain analysis to 280, which I think reflects more, you know, the real world of how we treat patients. But yeah, in clinical trials, particularly as pre-specified endpoints, you need to define a value, and I think 325 for the majority of analysis is justifiable.
Yeah, I see. Yeah, so okay, is there any further comments from the panel towards diabetic markers? I can see Peter is moving and shaking.
Yeah, it's confirming my talk. So it's interesting that we are shifting the focus in diabetes, which is an inner retinal barrier disease, to the outer retina. And that's what I've said. And your images, Anna-Theresa, who have shown that the visual acuity depends on the photoreceptor thickness from the ALM to the outer segments. It is very similar to my slides I've shown with macular off detachment. Yeah? A large photoreceptor thickness is prognostic for a good final vision after retinal detachment repair. And if you have a very short photoreceptor thickness, then it's a bad prognostic marker. In diabetes, it's always the same. We look too much on the inner retina. Of course, we treat with anti-VEGF the cysts and the thickness, but the result is still preserving the outer retina, because this is predictive for visual acuity. And I think this came out quite good in this course through all of the presentations.
Very well. So I would say, in the interest of time, we move onward, and it is now a particular pleasure to introduce Andy Pollreisz from Vienna to tell us about OCT biomarkers for diabetic retinopathy, also with the view of his particular interest for wide-angle imaging. So I'm very curious what he will show us today. Andy, go ahead.
Andy Pollreisz. Now you can see the slides. Yes. The diabetic retinopathy is a multifactorial disease. And we have some connection problems with Andreas Pollreisz. As it seems, not only the interpreters, but everyone. It's the internet connection which is not stable, so perhaps Dr. Stanzel.
Problems hearing Dr. Pollreisz. Apologies. We're hoping to resolve the technical matter.
Ansonsten würden wir Professor Munk vielleicht vorziehen und ich kläre das.
Otherwise, perhaps
Okay, ich hoffe, meine Internetverbindung funktioniert.
Professor Munk.
Yeah. So until we resolve the connection issues with Dr. Pollreisz.
Ausgeworfen worden. Also wir sind hier im Wide Field Imaging.
So we are in the wide field imaging. This is again Andreas Pollreisz with a quick white field OCTA. We have non-perfusion areas in different DR stages that we have looked at. And with a field of view of 18 by 18 millimeters, roughly 65 degrees, we were able to show that the non-perfusion areas, for example, they are marked in yellow on these images, that they are increasing with advancing stages, and in proliferative DR, this is shown very quickly. So the non-perfusion areas, do they have importance for clinic diagnosis? Yes, because we know where we have non-perfusion areas. In the course of time, for example, of at least 4 years, they have worst stages of disease, at least 2 steps of worsening of the DR stage course, and also the treatment for diabetic retinopathy. And we also show that those eyes who have a bigger non-perfusion base, they have more proliferal DR. Where do we need AI, for example, for such large surfaces, for example, and such large data, for example, to capture everything? How can we interpret it correctly? Now, with deep learning based algorithms, for example, and there are various research groups who have described it, and they are being used. And at the moment, you can also look at retinopathy stages and predict them also, and detect them with quite a good quality up to the smallest capillaries. With high-speed OCTA, for example, we can also show microaneurysms. You might ask yourself why it is important to show microaneurysms in the high-speed OCTA. Microaneurysms are a very important pathogenic factor in retinopathy. It's irregularities that show the diseases and pathologies on microcapillar level. And here you can see, for example, that very often OCTA was generated with an R generation, R scans, billions by scans per second, and we could detect much more than with a conventional color fundus photography done by experts. And also this determination quantification is important for clinicians. Why? Because we all know the PPLs, the predominantly peripheral lesions, it's micro and macrovascular changes that usually happen outside the standardized EDTRS field. And a study from the RC Retina Network, we know that the PPLs on wide field FA images, for example, if they are detected there, they significantly go hand in hand with diabetes progression. And that was much more significant than with a single fundus. So if we look at the PPLs, for example, try to look at them, and the OCTA in retinal non-perfusion, for example, the non-perfused retinal areas compared to the overall area, and we also did retinal non-perfusion areas that we also took, and we found out that PPL plus, he had a bigger non-perfusion index and also bigger non-perfused retinal areas. What's also a very important marker in the retina for diabetic eyes, it's neovascularization that show the status of the prolific diabetic NLV. We can use them very well for OCT and geography. And in the OCT scan flow, we show that above the inner limiting membrane, for example, here we can see it in B in red. The big advantage is that this non-invasive method, and it can be done within a few seconds, that neovascularization can be analyzed up front, so the therapies can be monitored elegantly. And we also looked, for example, at these white field pictures, how big should they be, not to lose any neovascularizations. And we looked at 59 eyes of 41 PDR patients. It's a 65-degree field of view, 18 by 18 millimeters, with a sensitivity of 95%. So we have to make sure that you get the right diagnosis of proliferative disease, because most of them are in diabetic neovascularization. Most of these wide field images, they take a lot of time. It's challenging in clinic and everyday practice. So therefore, good analyses and automated markers of the neovascular structures are very important, also for differentiating between intraretinal microvascular abnormalities, the IRMES, for example, that are not always visible, also for very proven and experienced clinicians. And here we have developed an algorithm for stable detection of neovascularization and neovascular lesions, for example. But what about the different micro and macro vascular biomarkers? Here, in case of diabetic lesions, for example, in different retinal areas, we have done analyses, and we have found out that most of the changing take place outside the classical EDTHS. We call it extended ring 1 and 2. And we could see very clearly that diabetic lesions, they have a very high statistical correlation with the appearance of intraretinal microvascular abnormalities. That led us to the conclusion, for example, that the combination of wide field OCTA and ultra wide field fundus picture, this has the potential to detect most of the diabetic lesions and to make it able to quantify them and also to do prognosis when it comes to imaging. Now I would like to shift your focus on the macula. And I would like to start with the ischemia, the diabetic macular ischemia with the photoreceptors. We have already shown it and seen it in the previous chats or lectures. And do you have another tip for the technology of imaging? With OCT, for example, we can use adaptive optics. This is a technology that makes it possible for us to look at aberration, for example, through the lens and the cornea, for example, and to level them out. So there on a very small field of view, for example, we talk about 4 by 4 degrees. Ultrastructures of the retina can be shown. Here you see, for example, at the bottom part, the little white dots, the hyperreflective dots. This is one individual photoreceptor. And what we also have seen in the study, for example, is that changes alone in the deep capillary plexus, for example, that you can show very elegantly with non-invasive angiography and OCT, that this ischemia shows that the integrity of the photoreceptors is already inhibited. With the DROCT technology, we can not only show photoreceptors, but we can also show them in 3D, more or less, on the different level of the photoreceptors. And here we see that there are ischemias, for example, that lead to problems with the photoreceptors. And that can be correlated very well with the retina malsensitivity, the microperimetry technology. So what we have seen here, it's inhibitions of the photoreceptor level, and that has directly an effect on retinal sensitivity, and then again on the visual acuity, for example, if the perfusion is limited. For the diabetic macular edema, let me sum it up a little bit, and I also try to take out some of my slides, as Dr. Lorenz also then covered some parts I had prepared for you. To sum it up very briefly, we know that the central subfield thickness, for example, and the treatment of diabetic macular edema do not correlate quite well. We also know that the group under Professor Schmidt-Erfurth at our hospital, it has shown some years ago that intraretinal fluids, also with a diabetic macular edema, can be shown and quantified very elegantly through the deep learning method, but also photoreceptors, for example, in a macular edema, for example, and diabetic retinopathy can be quantified automatically and detected. And it also Dr. Roberts also said, who had visited our clinic, and he has shown in a great way that in the T protocol, the retinal network, for example, the study of the 3 anti-VEGF studies, for example, that we can compare the results, and with deep learning, automated volumes can be generated, and they show that if you have a bad baseline VSUS, for example, or visual acuity, then combined with intraretinal fluidity, have an effect on the baseline, and there is significant correlation, for example, with the volumes of intraretinal fluidity after visual acuity after 1 year, and subretinal fluid had the biggest effect on the visual acuity as retinal fluid in general. And we show that with less and less fluid in the central fovea, for example, we had an improvement of 0.34 for the letter score and an intraretinal 0.15. And these data were also replicated in the real world. It's just a recent publication of the Coli Institute in Cleveland, and they have shown that with deep learning and algorithms, the detection of fluids, then it shows that the patients that have been treated for 12 months with the anti-VEGF treatments, for example, that they had less supraretinal treatment. And here you see the bars in blue of those patients who had the worst visual acuity outcome. This has taken me to the end of my presentation. Thank you so much once again for your attention, and now I'm looking forward to your questions.
Okay, so thank you very much for this excellent talk and all of these novel imaging modalities that we have at our disposal. Very, very beautiful pictures. A quick question. So the in the adaptive optics images, the ISOS line, is that the same as the EZ in OCT imaging?
Yes. Yes and no. There is this is the big dispute between from on the medical physics level between SD-OCT or swept-source OCT people and the AO-OCT people. In the AO-OCT field, it is believed that due to the high refractive index that's occurring right at the junction of inner segment, outer segments, that's better described as ISOS, and that the ellipsoid zone incorporates more reflective signals than is just seen with AO-OCT. But on a general level, and there are a lot of groups that kind of use these terms interchangeable. So you can, I think, use both terms here.
So basically, the adaptive optics imaging also showed that the vision is mostly dependent on the integrity of the ISOS or the EZ.
Yes. So correctly, we see this in so many studies. So I think that's and also Professor Schumann pointed out, I think that's the location to look at, and that's also the location in order to define the threshold or the the best visual acuity that we are aiming for the patients, because at some point of time during the course of diabetic retinopathy, a visual acuity of 100% is not the aim anymore. And sometimes we go back to 60, 50, even 40%, and that's then the goal that we aim to reach with our treatment of choice. And in order to determine this threshold, I think advanced imaging will be needed, and I think this will also be imaging tools of the near future in order to better define what we can get out of these sometimes, unfortunately, severely diseased eyes.
Yeah, excellent. And one more very last quick question before we get to our last speaker for today, Marion Munk. Just because you're such an expert in novel imaging, is there a future role for fluorescein angiography? Or do you reckon that it won't be necessary anymore in the near future?
So I'm just talking about diabetic retinopathy. I think with advancements in OCT technology, but also advancements in regular wide field color fundus imaging, which will be the immediate next future, I think that fluorescent angiography will have a limited role over the next years to come.
Excellent. Thank you very, very much. So we will continue to our last speaker for today, and it's with great pleasure for me to introduce Professor Marion Munk, who will be talking about the inner retinal layers today.
Erstmal vielen Dank für die Einladung. Es freut mich
Thank you
sehr.
very much again for the invitation. I'm really happy to see and meet again so many people I know since a long time.
Gut, wir haben jetzt schon
Okay,
gehört,
we've been learning a lot. We learned a lot about how many intravascular disease may have an impact on the outer retina. And I'll do it now the other way around. How about the changes on the inner retina when there is disease affecting the outer retina? We often ask to talk about the inner retina, the inner retinal layers. I think that's a quite interesting topic, which sometimes is underestimated. There is a very unspecific biomarker if you consider this part of the retina. So what you see here listed is a kind of diseases when we can say, well, so when to use a biomarker in order to diagnose a disease. Well, so basically, there are very good biomarkers, but a quite unspecific one. And that enables us to do some interpretation regarding different diseases generally. So it is about an inner retinal layer, and you really have to look at it very carefully. That's why it makes sense and is helpful if you consider the thickness of layers and of the retinal layers. For instance, this patient here, 20 years old, she came to us, had some vision problems. She said, I cannot see correctly. And if you consider the OCT, there are not a lot of change. But BCVA 0.4, and if you consider this image here, the scan, you can see the problem. So a pump lesion, the patient herself. So when we had to clarify her problem, so we saw there is a CNS vasculitis, an atrial myxoma, and that's why we had this. So you really have to identify this on the inner side of the retina. Generally, if you have a retinal atrophy, it's not easy to detect it, to identify it. Well, here it appears to be easier because, well, you have the atrophy here. You see the different thicknesses here, but in general, as we said right before, it's much easier to work with a map like this, the thickness map, because this enables us to see the extent of the inner atrophy of the retina, and if there is one or not. In addition, it really makes sense. It's really helpful to use this kind of maps in order to identify the progression, in order to realize the progression. If you have a progressive glaucoma damage, so then you can see immediately, well, there is a progression of the glaucoma. As said, the inner atrophy, this is basically a biomarker, primarily or secondary. And the so-called blue retina shown here on this map, well, there is, in general, there is a lower thickness, and that's one, again, this is a sign, this is a biomarker, because as you can see here, once again, an inner retinal thinning, this corresponds to an area of non-perfusion. So if you consider this map here with this retinal artery occlusion, so you can see the areas affected by this occlusion. As shown right before at the beginning of my talk, there are so many different diseases where we can use this as a biomarker in order to evaluate the progression or detect the progression of a disease. First disease to mention here is the uveitis. And well, here you see the posterior uveitis birdshot. And if you consider these birdshots, so then you see the atrophy, outer atrophy, but then as a secondary effect, the inner atrophy. So here we have an inflammatory reaction and then a secondary reaction. And then there is an inflammatory component inside the retina. We see a leakage, and that's why there's not only a secondary there is a secondary and a primary atrophy on the retina. And as said right before, the assessment of the thickness can be used as a method, as an approach to detect vascular leakage or periphery capillary leakage. So there is a nice correlation with the presence of perivascular, macular, and generalized thickening on OCT thickness, and on the other hand, there is a correlation with between the different thickening. So we will always have to evaluate these thicknesses. Another fact here, as a secondary complication, the nerve, optic nerve head swelling in the case of uveitis. And we have to analyze this swelling. If it decreases, then it may pass over to an atrophy. It's not easy to detect when this atrophy is beginning or when the swelling is beginning. And when does it pass over to the stage of an atrophy? And here it is very helpful to use the global RNTL and in addition the thickness map, because the studies showed that a decrease of this thickness is a good biomarker for beginning atrophy in the frame or in the case of a decreasing swelling. And the decreasing GCL correlates with the peripapillary vessel density decrease. Well, then unspecific biomarker, that means there are many other diseases, optic neuropathies. So this is always an important parameter for quantifying. Here, once again, a patient coming to us because of decreasing vision, worsening visioning. So the MRI grade 3 showed a glioma combined So the treatment was a combined radio and chemotherapy. Here you can see after 6 months the evolution, the progression. Basically no progression, but if you consider this here, the macular thickness or the thickness of the retina, when comparing it, here you can see a strong decrease, and on the other eye, there is a strong decrease as well in the color-coded area, as well as here in the quantification. So an MRI has been done again. And well, we can see in addition that as for the optical neuropathy, we can see a specific decrease of the thickness of the retina. Here we have a patient and you can see that it makes sense to detect on the one hand the disease and on the other evaluating the progression. At the beginning, the patients have a very low increase of the thickness. But if you consider the GCL, then you can see that GCL is presented in a thinned way already. This means GCL thinning is one of the first parameters to be seen with the patient. And the GC-IPL thinning in pre-symptomatic stage, first in the inner ring of the nasal sector, and then it progressively extended following a centrifugal and spiral pattern. As mentioned before, disease on the outer retina show an atrophy on the inner side. The inner atrophy can be used as a marker, as a parameter for disease on the outer retina. If you consider this here, if you do an AMD comparison between an intermediary SEC type passing over to wet type, then we see a significant reduction of the retina thickness. And then the patients, once they get wet and once they develop fluid, then they show a stronger retina atrophy. And we can see a difference between, on the one hand, the GCL thickness with patients which are following a therapy in comparison with the non-treated eye. And we know that there is a moderate correlation between the GCL thickness and the neurovascular appearance. And we have a moderate correlation with RPE atrophy and the GCL thickness at the follow-up. The more RPE atrophy you have, the thinner GCL will be. And what is very interesting, patients suffering this and in addition glaucoma, there we see a decrease in the macular GCL, but when their glaucoma is managed correctly, then this is comparable to patients who have only neovascular AMD but do not suffer glaucoma. And as shown by other studies, it is interesting to see that there is no decrease of thickness and that's why GCL RPE is much more sensitive. Last but not least, diabetic retinopathy. Here, the inner retina atrophy can be used as a biomarker. That's not surprising because there you have a neurodegenerative component as well, and that's why it's not surprising that with diabetic patients we have this retinopathy, but on the other hand, we have a reduction of the size of the vessels, and in addition, a reduction of the thickness of the inner retina. And these microvascular changes, or the diabetic retinopathy and its degree of severeness correlates with the GCL thinning. And that's why it is not surprising that when we try to, when we treat the patient, how fast there is a progression. And if, in addition to the OCT parameter, if we consider the neurodegenerative parameters, if we consider the thinning as well, then we'll have a better, we can do a better prognosis about the progression of the disease. And well, that's the end of my presentation. Thank you very much for your attention, and I'm looking forward to your questions.
Okay. Excellent talk. Thank you very much. A quick question regarding inner retinal atrophy. Is there anything positive that we can tell our patients? Is there any disease where inner retinal thinning is may recover, or is it always permanent?
That's a very good question. I mean, sometimes in optic neuropathies, for example, or in due to, for example, tumor stages or so, you can sometimes see kind of a little bit of thickening, but usually it's a continuous thinning. I mean, even in normal people, you see a continuous decline in inner retinal thickness over time. As much as the age, the more the age, the thinner it gets, and so it's usually general slope downwards and not a slope upwards. In some cases, you may have a false positive thinning effect when, for example, you have ganglion ciliary cysts or retinal nerve fiber cysts in diabetes or diabetic macular edema or retinal vein occlusion patients, and of course, when these cysts go away, then you have a thinning effect. But usually these kind of cysts are not a good prognostic marker, because in general, if you have cysts already in these layers, usually these patients have a poor prognosis in terms of the visual acuity. So in general here, it's also not a good thing if it's getting thinner. Yeah.
And maybe a very direct question, but if you would have to pick between ganglion cell layer segmentation and RNFL segmentation, is one better than the other, or do they only work in conjunction?
So I think it's always useful to look at them in conjunction, but in general, if I have to choose, I would, I think for me, the macular ganglion cell layer thickness is less error prone, at least if you have no fluid, than the retinal nerve fiber layer. Yeah.
Excellent. Thank you very much.
Thank you.
So I think with this excellent talk, we can conclude a fantastic macular course, and I would like to give the word to Professor Schurmann.
Ja, vielen Dank.
Yeah, thank you very much.
Thank you so much. It was a fantastic panel. I think it has been much appreciated with the record number of participants that we had. And we are quite good in time. Of course, every lecture could have been discussed for 1 hour more, and next year we are already looking forward to that. We're going to have our next training, and we have announced already that it was an advanced course and not a beginner's course, and all our brains are boiling, also mine. We cannot take along everything, but I think we have all taken along that we need a change in focus on what we look at, and I'm very sure that as of next week you will have a different view at your OCTs. The lecturers told us all your secrets, and you see that the world of OCT and macular diagnosis is so much more than we can integrate in our everyday life. We are only boiling with water, so to say, in our everyday life. But the advanced technologies like AI, for example, these are all the things that are entering slowly but surely our everyday life. And in the next years, our macular diagnostics will be improved not only for special questions, questions, but also for everything. I would like to thank all our lecturers. Thomas, from the start to the end, you have been with us. That's great, wonderful. But also thanks to all our lecturers that I was able to see them again. I would like to thank the co-facilitators, Boris, Stanfel, Philipp, Roberts. It was for us really a great pleasure and an honor from Sulzbach to be able to serve this great panel. And I would like to thank the sponsors who have made all this possible. And therefore, we are going to show once again the slides from the sponsors at the very end. And we are happy about that. Thank you so much and see you next time. Thank you and bye-bye.